focused on up to that point. And even more discouraging was the fact that we had found no treatment at all, not a single treatment that was effective in patients with heart failure and preserved ejection fraction. But let me quickly review with you how much things have changed in the past 10 years. And I'm going to give a bird's eye overview because I know people speaking after me are going to cover certain of the topics in more detail. So let's start with heart failure with reduced ejection fraction. And 10 years ago, we sort of come to the end, we thought, of the era of neurohumoral antagonism. We knew that blocking detrimental neurohumoral systems in heart failure was beneficial, but we didn't seem to be getting any further at that point. But in 2014, there was a real paradigm shift, which was because of this man, this Argentinian scientist working in Canada, and Adolfo de Bode discovered what we came to describe as the natriuretic peptides. These peptides secreted by the heart, but we also know by blood vessels, by the kidneys. So when I went to medical school, the heart was a mechanical pump. Nobody thought it was an endocrine organ, and nobody thought that it could protect itself by secreting these peptides that were vasodilator, acted on the kidneys and also inhibited pathological growth. And for a long time, and in fact it took fully 25 years, for a long time there was a lot of work done to figure out how we could pharmacologically augment natriuretic peptides, how we could enhance that endogenous protective beneficial neurohumoral system. And the way eventually it was figured out this could be done was by inhibiting the enzyme neprilysin, which is responsible for breaking down natriuretic peptides and indeed other vasoactive and indeed metabolically active peptides, and those other actions may be important as well. And eventually Novartis developed a combination where a neprilysin inhibitor was added to an angiotensin receptor blocker, and we had the opportunity to do a very large clinical trial called Paradigm Heart Failure that really looked at the addition of a neprilysin inhibitor on top of conventional therapy, which at that time was a renin-angiotensin system blocker, beta blocker, in mineralocorticoid receptor antagonist. And 10 years ago, we were able to show that adding a neprilysin inhibitor to conventional therapy further reduced morbidity and, importantly, mortality. And I showed that little bit of history just so that I could also point out to you that, in fact, work continues to this day to try and continue to exploit that potential therapeutic pathway, because there are drugs that act as direct agonists of the natriuretic peptide receptor, which are under development. I'll show you something about that in just a second. And there are other drugs that inhibit the specific phosphodiesterase PDE9 responsible for the breakdown of cyclic GMP augmented by natriuretic peptides within the cardiomyocytes and other cells. So there are these two additional approaches being developed to try and further enhance that pathway that neprilysin inhibition demonstrated to be so beneficial. And just a few weeks ago, published online in Nature, was this first report of a specific long-acting natriuretic peptide 1 receptor agonist demonstrating proof of concept. And earlier this year, colleagues and myself presented these data at the Heart Failure Association meeting. Again, proof of concept data showing that inhibiting phosphodiesterase 9 in patients with heart failure could increase cyclic GMP, exactly as we hoped we could do. And there's even more novel approaches being explored to doing the other part of what sacubitril valsartan does, in other words, blocking the renin-angiotensin-aldosterone system. This is an agent that knocks down hepatic production of angiotensinogen, a small interfering RNA intervention, and this may again have specific advantages potentially in patients with heart failure, in particular sparing the intrarenal renin-angiotensin system. So all of those mechanisms that we've worked on in the past, we're continuing to work on. But the more recent and really completely novel breakthrough, moving us to a completely different era of heart failure therapeutics, was the discovery of the SGLT2 inhibitors, drugs that were originally, as I'm sure you know, introduced to treat patients with type 2 diabetes, drugs that block reabsorption of glucose in the proximal renal tubule, along with sodium, drugs that have revolutionized the treatment of chronic kidney disease, and as we've shown in 2 large trials in patients with this particular type of heart failure with reduced ejection fraction, also revolutionized the treatment of HFrEF. And the 2 trials were DAPA-HF and EMPEROR-reduced, using different agents in this class. So these are completely independent trials, different drugs within the same class. You can see here, if you look at these 2 panels side by side, they're almost indistinguishable. It's very rare to see evidence replicated so exactly as we saw in these 2 trials. And this is evidence that an SGLT2 inhibitor further reduces mortality and morbidity when added to those other neurohumoral agents that we had previously worked on. And the whole story of SGLT2 inhibitors has been quite remarkable, because to this day, we really don't know exactly how these drugs work. We know that they do work. We know that they do lots of different things, and I've tried to summarize those on this slide that might be beneficial. But truthfully, at least in my opinion, I don't think we know exactly how they work, but they have multiple actions, probably like most drugs, that are potentially beneficial in patients with heart failure. And in some way, they appear to be organ protective, protective of the heart, protective of the kidney, but also the pancreas, the bone marrow, and some people believe the liver as well. So in the past few years, suddenly we now have this paradigm for the treatment of patients with heart failure and reduced ejection fraction, this so-called 4-pillar model, although actually I think there are technically 5 pillars here. There are at least 5 different mechanisms of action, these life-saving drugs. And there's even another breakthrough with maybe more modest benefit, an agent called vericiguat. Vericiguat is a soluble guanylate cyclase stimulator. It's a drug that acts in this intracellular enzyme again to increase cyclic GMP, although through a different intracellular pool. And in a very large trial called Victoria, vericiguat was shown to have a rather modest benefit, at least in terms of relative risk reduction, this 10% reduction in risk of cardiovascular death or worsening heart failure, hospitalization for worsening heart failure. Statistically significant, but in relative risk reduction terms, rather modest. Now the question is, was that modest benefit because of the drug? In other words, because vericiguat doesn't work very well? Or was it because the trial that I just showed you actually enrolled a very different patient population than the trials I've spoken about so far? Because the Victoria trial was a trial that enrolled many patients who were either in hospital with worsening heart failure, who'd been recently discharged from hospital with worsening heart failure, unlike the other trials that enrolled a predominantly more chronic outpatient ambulatory population. So there is now a second large trial with this compound vericiguat, fully recruited. We should get the results of this next year. And this trial has been conducted in a population very similar to the other positive trials I discussed a few minutes ago. So I'm going to change gears now completely to talk about the remainder of patients with heart failure and so-called mildly reduced and preserved ejection fraction, and ejection fraction above 40%, patients who've been neglected until very recently, patients in whom we had no proven evidence-based treatment until very recently. And in fact, even back in 2021, this would be the sort of slide you would have seen during a presentation like this, where there was simply no evidence-based therapy available, unfortunately, for those patients. But again, the SGLT2 inhibitors completely changed that story. And just like the two trials that we have in patients with reduced ejection fraction, we also have two large trials with dapagliflozin and empagliflozin in patients with heart failure and an ejection fraction above 40%. And that's the DELIVER and the EMPEROR preserved trial, published in 2021 and 2022 respectively. And you can see again this remarkable consistency of benefit, around a 20% relative risk reduction in the composite in this particular slide of cardiovascular death or heart failure hospitalization, although in this heart failure phenotype the benefit driven predominantly by reduction in heart failure hospitalization. So the first ever breakthrough in patients with this type of heart failure. And in Europe, because we thought this was so important, there was actually, for the first time ever, an update of the heart failure guidelines, breaking out of the normal 5-year cycle to produce this earlier update so that we could give a recommendation, and indeed, as you can see here, the strongest possible recommendation for the use of SGLT2 inhibitors in those patients. But in the past few weeks, there's been a second major breakthrough in the management of patients with this type of heart failure, and that's using a newer type of an old-fashioned drug. I'm sure most of you know about mineralocorticoid receptor antagonists, sometimes called aldosterone receptor antagonists, the classical steroidal MRAs are spironolactone and eplerenone, but there's a whole family of chemically distinct agents that also block this receptor. They're called non-steroidal MRAs because they don't have the steroidal chemical structure, and the lead compound in this class is a drug called finerenone, but there is a whole new class. And of course, there are lots of discussion about how they differ from classical steroidal MRAs, including the fact that they may have a different tissue distribution with relatively greater distribution to the myocardium than to the kidneys. And we had the opportunity, again, to conduct a large randomized trial called FINE-ARTS-HF with finerenone in patients with heart failure and mildly reduced or preserved ejection fraction. So we just presented these data a few weeks ago at the European Society of Cardiology. This was a large global trial, as all our heart failure trials are these days, with 37 different countries participating, and we had 6,001 patients validly randomized, as you can see here. Very different type of heart failure than heart failure with reduced ejection fraction, which I spoke about earlier. These patients are much older. The average age here was 72. Our oldest patient was 94. And as you can see, almost half of these patients were women, unlike heart failure with reduced ejection fraction, where only about a quarter of patients are women. These patients tend to have more comorbidity, more likely to be obese, more likely to have diabetes. Many have concomitant atrial fibrillation, and almost all of them have a history of hypertension. Because we started this trial before the SGLT2 inhibitor evidence had been presented and published and incorporated into guidelines, only about 14% of patients were on an SGLT2 inhibitor in fine arts HF. So we had this sort of same type of endpoint, although we looked at total events rather than time to first event. But you can see the focus was on cardiovascular death and total worsening heart failure events, predominantly heart failure hospitalizations. And we saw a 16% relative risk reduction in this primary composite endpoint, which was highly statistically significant. Although, just like the SGLT2 inhibitor trials, this benefit was driven predominantly by reduction in heart failure hospitalization. And in fact, the rate of cardiovascular death in these patients with this type of heart failure is relatively low, which is surprising given the completely different picture in the other type of heart failure with reduced ejection fraction. There was consistent benefit across all of the subgroups that we looked at. That's very important because there were two in particular that we were interested in. One was left ventricular ejection fraction, because we had sort of thought that many drugs acting on neurohumoral systems probably were not beneficial in people with a completely normal ejection fraction. But in fact, if you look across the spectrum of ejection fraction here, you can see the continuous hazard ratio is really consistently below 1. And we saw no interaction between ejection fraction and the effect of treatment. In other words, no suggestion that ejection fraction modified the benefit of treatment. And then, of course, the other subgroup that's particularly important is the subgroup of patients who were receiving background treatment with an SGLT2 inhibitor. And actually, the unique thing here is that we can look at this interaction between these two classes of drugs in both directions, because in our SGLT2 inhibitor trials, we obviously had people who were in the mineralocorticoid receptor antagonist at baseline, and in fine arts, we had people who were on an SGLT2 inhibitor or not at baseline. And what you can see is whatever way you look at this interaction, the point estimates completely line up here. There was no hint of an interaction between these two therapies. In other words, they truly seem to have complementary and additive benefits. And again, if you look at the two trials, or two of the trials side by side, which I've done here, where I've put the same endpoint in DELIVER and fine arts HF, you can see that actually the treatment effect of these two therapies is very similar, but remember, they're not competing, they're additive, the benefits are additive. And finally, just to show you, I think, one of the most surprising findings in this trial, we had a pre-specified exploratory endpoint looking at new onset type 2 diabetes, and we saw that this was reduced by about a quarter, and there's a very robust, significant benefit. And this was a surprise because we have evidence from older studies that spironolactone is metabolically unfavorable in patients. So just to finish up with, I know there's another talk later about GLP-1 receptor agonists, but they are of some interest in patients with heart failure. And there are 2 trials, the STEP-HFpEF trials, relatively small, relatively short-term trials in people with heart failure and preserved ejection fraction living with obesity, where the GLP-1 receptor agonist semaglutide improved symptoms, improved functional capacity, reduced weight, of course, and reduced high sensitivity CRP. Now, I think it's still uncertain, or at least it is to me, what exactly those trials are telling me. Is this about just the treatment of obesity in patients with HFpEF, which is very important, or are these drugs doing something more than that? Is there some other pharmacological action? And there may well be. There is another trial that we'll hear the results of in a couple of weeks, the SUMMIT trial with a related compound. It's a GIP and GLP-1 receptor agonist. We already know from a company press release that that trial is positive. So maybe we're building pillars of therapy for patients with heart failure and preserved ejection fraction. I'm just going to very quickly look ahead, tell you what to look out for in the next couple of years. Inflammation seems to be very important in patients with heart failure and preserved ejection fraction. There's a big trial, nearly fully recruited, looking at an anti-IL-6, interleukin-6 intervention. So again, we will find out whether this approach bears fruit. And again, it's conceivable that when somebody gives this talk in 3 or 4 years' time, you'll see a figure like this, just like we have for heart failure with reduced ejection fraction. And there are other interventions being developed in patients with heart failure, preserved ejection fraction. There's a different type of anti-aldosterone therapy, an aldosterone synthase inhibitor, being studied in a trial called EASY-HF, which you can see here. And finally, I want to just say that I realize I've focused on pharmacological therapy. I fully understand there's an important role for devices, other interventions, and surgery. And in fact, one of the really big things happening in Europe at the moment is that I thought there were 2, but when I looked on clinicaltrials.gov a couple of days ago, there are now 3 large trials looking at catheter ablation for the treatment of atrial fibrillation in patients with heart failure. So this is where we are. Things probably not going to change very much by next year, although vericiguat could be more strongly recommended if the VICTOR trial turns out to be positive. And it's likely that we'll see some sort of regulatory labeling for anti-obesity therapies in patients with heart failure, preserved ejection fraction, and concomitant obesity. Thank you very much indeed.
Thank you, Professor McMurray, for an excellent overview of a very difficult subject. If I may ask a question, those of us who treat heart failure patients and the patients themselves are daunted with the number of medications they are taking. Also, for example, like ARNI or SGLT2, you can see some patients respond better than others. Where are we in terms of individualizing treatment of these patients?
So I'll start with the polypharmacy issue, if that's okay. So yes, there are a lot of drugs because, of course, these patients are on many other drugs for their other medical problems, of which there are often many. And that is a challenge, but I think there are 2 things that I do in my practice. So one is when I start a new drug, I always try and stop a drug that might not be needed. And I think you can almost always do that. A lot of our patients are on what I would call legacy drugs, drugs that when you look at them, you scratch your head and you think, why is that patient on isosorbide or amlodipine or whatever? If you're starting an SGLT2 inhibitor, you can stop their DPP4 inhibitor if they've got concomitant diabetes. And then the second thing is, if you've got time, talk to your patient about why you're giving those drugs, because I have honestly yet to meet a patient who said to me, no, I don't want to take a drug that will probably make me feel better, hopefully reduce my chance of being admitted to hospital and increase my survival. There are very, very few people, I think, who will say no to that. So sometimes it's really people understanding why it is that you're giving them the treatment. In terms of individualizing therapy, I struggle with that because I don't think we're anywhere close. And you said that some people seem to respond more than other people. Problem is that the fact that the patient is even alive and talking to you, even if they don't feel better, may still mean they are a responder, because if they weren't on the treatment, they mightn't be coming back at all. The trajectory of their heart failure might have been rapidly downhill and they might have died. So ascertaining response is actually a very difficult thing to do.
Thank you. Professor Triposkiadis has a question.
So do I. It's not mine.
So I have a question for you. Okay. First of all, I think that you belong to those that believe that heart failure with medium raised ejection fraction is an entity that is doubtful that it is not, or am I wrong?
I don't belong to that group at all. In fact, I'll let you into a secret. In the last ESC guideline group task force, we had a vote to get rid of it, but unfortunately we didn't get 70% of people vote.
I'm sorry, but nevertheless, it has been recently published by several
Yes.
experts in the field
Yes.
that this entity is non-existent.
Yes.
And also, if you remember the New Zealand Australian guidelines, they also argued that this entity is not existent. And the question that I have for you is, what does it happen? Is it a disease? How can you treat something you cannot define? And I have an argument for this.
Okay.
We have two algorithms,
Okay.
the American and the English,
Yes.
that are discordant. So what are you going to treat?
Okay. So just to be clear about so-called mildly reduced ejection fraction, I completely agree with you. The error measurement around ejection fraction is actually wider than the so-called mildly reduced category. I'm pretty confident that by the time we get the next guidelines, there will be 2 ejection fraction categories, and the dividing threshold will be 50%. And I think the mildly reduced will be done away with. But this time, the guideline task force were unwilling to make another change so soon after the last guideline. So that's the historical background. In terms of heart failure with preserved ejection fraction, well, I think it's as much a disease as heart failure with reduced ejection fraction. The first time the term reduced ejection fraction was ever used was in 1991 with the publication of the SOLVED treatment trial, the large trial demonstrating the benefit of enalapril. And the disease was defined by the trial and the therapy that was shown to be effective. And I think recently with the SGLT2 inhibitors and with finerenone, we now have drugs that have been used effectively in patients who've been enrolled on the basis of very simple clinical criteria, 3 criteria. One was having the signs and symptoms of heart failure. The second was having structural heart disease, meaning left atrial enlargement or left ventricular hypertrophy, and the third was having a very modest elevation of natriuretic peptides. If people qualified on those three criteria, they could be enrolled, and now we have trials that are positive and treatments that worked. So I would say to you, that's the disease. It's been defined by the trials, but I would say to you that so was the so-called condition heart failure with reduced ejection fraction. It was defined by clinical trials.
Thank you very much.
Well, we're moving on to the next presenter, Dr. Randall Starling. Dr. Starling is board certified in internal medicine, cardiovascular medicine, and advanced heart failure and transplant cardiology. He is professor of medicine in Cleveland Clinic and staff cardiologist in Robert and Susan Thomas Department of Cardiovascular Medicine. And nowadays he's serving as interim head of section of heart failure and transplant medicine and medical director of Kaufman Center. Professor will present to us durable mechanical circulatory support today and tomorrow. Glad to have you here, Professor.
Thank you very much. So we just heard an amazing lecture primarily related to pharmacologic therapy. So this is going to be isolated to patients with advanced heart failure. And before I begin, I have no disclosures that are relevant, and I certainly want to thank the sponsors and the organizers for the opportunity to be here. So, if we look at the guidelines and we come to the far right-hand side, this is stage D heart failure, refractory heart failure, and what we have to offer these patients is relatively few choices. We have transplantation, which is really almost a boutique therapy that only applies to a small percentage of patients, even in the US. Palliative therapy can be offered, and the focus of my presentation today is what the journey has been with LVAD therapy, left ventricular assist devices. So I want to begin by saying that the LVAD that I will discuss today is FDA and CE mark approved. This requires a surgeon, a cardiac surgeon, to open the chest, a median sternotomy, to do the implant. And one of the major barriers to this therapy in the world has to do with the cost. There's the initial upfront cost of the device, which would typically be in the US, $70,000 just for the device. And there's a continuing cost related to maintaining the therapy and some of the details related to the driveline that I will mention. So I want to take you through a journey of how we got to this point with LVAD therapy. And again, to emphasize, median sternotomy, all LVADs now, unlike pacemakers and defibrillators, have a driveline that is a percutaneous, comes through the skin to a power supply. Having said that, this is a therapy now that is mainstream. It has class 1 evidence as far as its utility, and people can live relatively normal lives with some exceptions that I will show you. So to begin the history of this, we go back to 2001, and this was the rematch study, which, as you can see, there were less than 200 patients in this study. It was a randomized trial looking at the original LVAD, known as the HeartMate XVE. This was a large pump. It was implanted in the abdomen. It was a pulsatile pump. And make note that the 1-year survival was 52%, the 2-year survival was only 23%, but it was far better than medical therapy. And the medical arm controls about 75% were inotrope dependent. And you can see the mortality in this group at 2 years, there's basically no survivors. The biggest pitfall of this device was it lasted about 18 months, and then it would have to be replaced. So, as this technology did not take hold in the US, it was not embraced for many of the reasons that I just explained. Another LVAD came along. This was now, instead of a pulsatile pump, it was an axial flow pump. So this is a device that is maintained at 9,000 to 10,000 RPMs. Again, it was implanted below the diaphragm, and in a head-to-head comparison in a randomized clinical trial of patients with advanced heart failure, the blue line, which is the new HeartMate 2 versus the original device that I showed you, the probability of survival was much improved with this device. So this really brought a new era as far as the use of the LVAD. But that era came to a bit of a halt, that about 5 years into mainstream use of this device, we began to see that more and more patients were having a condition that is known as pump thrombosis. And bear in mind, these are patients that are on warfarin and aspirin, but they were developing a thrombotic material that would lead to pump stoppage. Many different algorithms, including thrombolytic therapy, were tried, but ultimately the only treatment for this was to replace the device. This had a big impact on clinical trials. It had a big impact on the use of the device as this was recognized, and it had a very big impact on industry as far as accelerating the pace to develop new technology. That new technology that you see on this slide is the HeartMate 3. So the HeartMate 3 is totally different than the first two pumps I showed you. This is a magnetically levitated pump. It has no bearings. It operates at about 5,500 RPMs. And this Kaplan-Meier shows event-free survival, which includes pump thrombosis, replacing the pump, strokes, and you can see that the new pump performed much, much better. And why did it perform much better? The primary reason for this is that this new pump essentially eliminated pump thrombosis. So at 24 months, you can see the red bar versus the green in the HeartMate 3. The risk of pump thrombosis is less than 2% with the new pump. And if you extend this through 5 years of follow-up, which we now have extensive follow-up with the HeartMate 3, again, the event-free survival is highly statistically significant improved with this pump. If you look at overall survival, it's also improved, but this includes patients that had pump thrombosis with the HeartMate 2 and were then converted to a HeartMate 3. So shown at 5 years, comparing the two new pumps, you can see across the board as far as bleeding, stroke, pump thrombosis, the new device is much, much better. So in the United States, and especially in Europe, the HVAD, which is shown on the far right, which was a similar centrifugal pump. It was ultimately purchased by Medtronic, but it was taken off the market. The primary reason it was taken off the market, which happened in June of 2021, was the company's recognition that the incidence of neurological adverse events, specifically strokes, was much greater with the HVAD. Now, up until this point, there had been no head-to-head comparison done in any clinical trial between the HeartMate 3 and the HVAD. So we had to go to registry information, and in the US, there is a registry. It's got over 25,000 LVAD patients in it, known as INTERMAX. So we were able to go into the INTERMAX registry, which is adjudicated, and look at HeartMate 3 versus the HVAD, and comparing at 12 months, the risk of stroke and TIA was 92% in the HeartMate 3 versus 82% in the HVAD. This was well recognized amongst physicians. They essentially had stopped implanting the HVAD. So now in the United States, we only have one LVAD available, which is the HeartMate 3, which is owned by Abbott at the present time. So comparing the HeartMate 3 to the HeartMate 2, again, less pump thrombosis, less neurological complications, less bleeding with the same anticoagulation regimen. However, the stroke rate is not perfect. It is 9.9% at 24 months. Gastrointestinal bleeding, as I will show you, which is a unique phenomenon that occurs in patients with continuous flow versus pulsatile flow. So this is characterized by arteriovenous malformations. They can be seen in the stomach, in the small intestine, the large intestine. Some patients have bleeding in the bladder. It can be seen in the uterus. It can be seen in the brain. So bleeding complications with non-physiologic continuous flow are a limitation. How does this relate to keeping people out of the hospital? So this again remains a big challenge with the current therapy. So this is from the registry, and what you see in this is that at 5 years, essentially every patient has had a hospitalization for one reason or the other, which I will focus on 3 main adverse events: the GI bleeding, driveline infection, and right heart failure. So when I go back to the hospital on Tuesday and I make rounds, I will have a patient with an LVAD in the hospital that will have these complications. So this is a very prevalent situation. However, LVAD, when a patient has got a choice between dying of their heart failure or getting an LVAD, most patients will choose the LVAD because it absolutely improves survival. So we have a number of challenges that we are still facing with current LVADs, even the best LVAD that we have today. So I want to share with you some data from just one center, the Cleveland Clinic, which is where I work. So we have been implanting LVADs at the Cleveland Clinic for 30 years. Last year, in 2023, we had a volume of about 85 patients, which if you compare that to our cardiac surgery volume, which is over 4,000, this is a very small part of the practice, but it's a very important part of the practice for the patients with stage D heart failure. So just looking at the demographics, 25% female, the mean age is 61. Some of these patients were actually on the pathway for transplant, and others were patients that were not eligible for transplant for a variety of reasons. But this is the most important slide with the data that I want to leave you with, that any LVAD center that has experience can expect these types of results. 88% 1-year survival, 5-year survival of 58%, and you can put that up against most heart transplant programs in the US or most in Europe, and these survivals are equivalent. What is the big difference between the LVAD and the transplant? The adverse events. Those are the challenges that we still face, but for a patient with no options, this can give them a survival advantage. And again, we are challenged by the rehospitalizations for the reasons that I just showed you. And this is some data from our center that we published this year, but it falls into these 4 buckets: neurological, gastrointestinal bleeding. The average length of stay for a patient admitted with a GI bleed is about 7 days. They undergo endoscopy, many undergo endoscopic procedures. Driveline infections. Once the driveline goes away and we have an internal power supply, it will be a great thing, but right now, driveline infections are a challenge. And remember, the LVAD is for the left ventricle, and many times the right ventricle improves when you unload the left ventricle, but that doesn't always happen. And there are some unique things that happen with LVAD that we don't fully understand, that when the LVAD is pulling blood out of the left ventricle and the septum can shift, it can have effects on the right ventricle that some of these patients will develop right ventricular dysfunction. So unequivocally, LVADs improve 6-minute walk distance, and it's dramatic. So if you look at CRT, cardiac resynchronization, in the original Miracle trial, the 6-minute walk improved by about 34 meters. LVAD, it's about 150 meters. So this is a dramatic change. And this slide shows the changes in NYH class. So whether you look at any of the patient-reported outcomes, virtual analog scale, etc., Kansas City, the LVAD is generally the winner. So what are some of the recent developments that have happened? So the question was asked, with this new HeartMate 3, no pump thrombosis, can we reduce the risk of bleeding by eliminating the aspirin? So a clinical trial was done. It was in Europe and the US, known as the ARIES trial. So the patients were randomized to stop aspirin, to be on a placebo. It was double-blind, placebo-controlled, and the trial was overwhelmingly positive, with a reduction in bleeding events, reduction in hospitalizations, which translated to a reduction in cost. So as of July of this year, the FDA has changed the label that aspirin is no longer required with the LVAD, and the standard is warfarin alone with a target INR of 2. So that leads to another question, which has been asked many times, which is, what about using a NOAC? Can we give these patients a non-vitamin K anticoagulant to simplify things? Random small studies have had mixed results. This is a recent proof of concept that was published by a single center, Inova, Chris O'Connor's team. It was only 30 patients. It's not definitive, but from a safety standpoint, we're currently seeking between industry and the NIH the opportunity to do a proper clinical trial to try to answer the question between warfarin and apixaban. Right now, we don't know, and right now, it's recommended not to use apixaban. Even a smaller patient cohort, just 8 patients that had a HeartMate 3 that were taking a NOAC off-label that underwent transplantation, they had an increase in bleeding complications. So the warning now is not to use NOACs until we have more definitive data. So we get very excited with the initial results of LVADs, but we learn over time that there are complications that we didn't originally recognize. And what we have found with the HeartMate 3 is this entity known as outflow graft obstruction. So this is a situation where a patient will come in, their LVAD is alarming, they don't feel well, cardiac outputs are compromised. So we've learned that debris can accumulate in the outflow graft. There can be twisting at the bend relief where the connection is with the LVAD. There's a variety of reasons. The good news is that at 2 years, this is occurring in anywhere between 2 and 4%. So it's not a highly common phenomenon. And this is just a picture showing one approach where you can percutaneously get into the outflow graft and do stenting and try to relieve this. In other cases, through a small thoracotomy, sometimes the surgeon can go in depending on where the obstruction is. So we routinely use contrast-enhanced CT scans to try to make this diagnosis, which oftentimes can be effectively treated. So earlier in this Congress, Stavros Drakis gave a presentation on cardiac recovery. And I just want to reinforce that this is an ongoing active area of research to look at the opportunity to have a patient with heart failure. They receive an LVAD, they're unloaded, but their native heart function improves. And a very small study known as Restage, it was only 40 patients. It was not randomized, it was observational. But we saw in that study that at 36 months after LVAD implant, almost 50% of these patients, which were highly selected non-ischemic cardiomyopathy of recent onset, improved. So stay tuned, there's more to come on this. So we need competition, and now there is an LVAD developed in China that will undergo clinical trials beginning in the US very soon. Our site is becoming activated. This is known as Debrio Health. It's approved by FDA, so it will be randomized against the HeartMate 3. Finally, this is registry data that was just presented in younger patients, less than 40, showing at 1 year, 94% freedom from stroke, 97% freedom from device malfunction. Patients doing very well. That has led to the concept, if you have a young patient and you want to give them 25 years of life, because remember an a transplant has a median survival of about 12 years, you should think about an LVAD first and subsequently a transplant down the road. So I think an LVAD is a legitimate alternative to transplant. Final slide is Team HF, which is again just launching, which is combining an LVAD with a pulmonary artery sensor to fine-tune and treat the patient's heart failure. With that, I'll close, and thank you for the opportunity to provide this update on LVAD therapy. Thank you.
Thank you very much, Professor Starling, for your wonderful presentation about LVAD therapy nowadays. I would like to comment on something and ask a question. And unfortunately, here in Cyprus, we do not have facilities for LVAD therapy, so we have to send our patients abroad through ministry. We take approval and then we send our patients either in Greece or in Germany or in other countries that can provide LVAD therapy for our patients. And there are several doctors here in Cyprus that can do the follow-up and in connection with remote control with the other countries. So I would like to ask, where would you believe, for Cyprus, what would you recommend is the optimal time that we put our patient on a list for LVAD therapy? Is it still Intermax 3?
So, I'm sorry, I'm getting a reverberation. Could you repeat the question? Where should we put our patients in Cyprus? We don't have LVAD therapy. On the list, is it the same as in the US? On Intermax 3? Think about like being a remote city in the US. We'll have to send patients 2 or 3 hours. Yeah, maybe. Okay.
And also, our waiting list for the approval from the ministry is medium 3 months.
I think it would be practical for patients to receive LVAD therapy in Cyprus. So in the US, for example, I'm in Cleveland, Ohio. The population is about 400,000 people. So we have many patients that come from other states. They live in very rural areas. So here's what the contingencies are. We have a team that has to go out. They have to check the power supply in their home. They have to make sure that they have a generator, if possible, in case of a power outage. They will go to the local fire department to make sure that the fire team has understanding of LVADs if there is an emergency. So that's pretty standard for LVAD care. We have something that's called shared care. So if a patient in Cyprus got an LVAD in Athens, for example, the Athens LVAD team would maintain primary responsibility to take care of that patient, but they would hope to work with a local team that had some training that could step in an emergency. Most of our LVAD patients, if they're in Florida, North Carolina, another state, and they have a serious problem, they will come back to Cleveland, Ohio, or alternatively, because in the US, there are many major LVAD centers all over the country, they can go to a local LVAD center.
Thank you very much. Any question from the audience? Yeah, please.
Okay. Thank you.
Wait a second, Professor Starling. We have a question from the audience, please.
It's okay.
No, he's returning. Okay.
Well, thank you for this wonderful lecture. I have a question regarding anticoagulant treatment of HMA3 patients with apixaban. You showed a little data with apixaban and warfarin in a few patients. So, and your idea is that we still don't know, but what you showed there showed a clear benefit for apixaban. So is your feeling that apixaban and the other factor 10 inhibitors will take over warfarin in this treatment? Because we know for mechanical valves that there is some, hesitancy to use warfarin, to use the newer drugs. What's your feeling about that?
So,
I know
No, the slide that I showed was only 30 patients and very short follow-up. So there are other studies that have shown danger with apixaban. So it's a very open, unsettled, unanswered question. We have done some calculations based upon event rates, and we think we would need funding for a study with a minimum of 400 patients to make a comparison in the HeartMate 3 between apixaban and warfarin. And the other complicating factor is that we know that warfarin without aspirin is safe, but with apixaban, the trial would probably have to include a warfarin-only arm, an apixaban and aspirin arm, and an apixaban-only arm. So it's complicated. Okay.
Thank you very much. We'll move on to the next session. Thank you all for attending this session.
Next session will be commented by Dr. Katerina Naka, Dr. Nikos Karpetas, Dr. Giamas Grigoris, and Dr. Angeliki Mouzarou. Now we would like to call upon the chairs, Dr. Andreas Sinetos, Dr. Spiridon Papayanou, and Dr. George Karvelas.
Well, let's proceed to the next session. It's a session about mainly about heart failure. We have 5 experts in the field. All of them, they are very experienced in the field. They are also experienced presenters. So we would like, if it's possible, to respect as much the time so that we will not be out of time. So I would like to ask for the first presenter, Dr. Andreas Xanthopoulos, to give us a lecture about the SGLT2 inhibitors, a new medication. And the big question in this topic is if it's a therapy for all patients with heart failure.
Thank you very much. Thank you very much. I'd like to thank the organizing committee for giving me the opportunity to give this lecture in front of leaders in the field of heart failure. It's a great honor. So my talk is about SGLT inhibitors in heart failure for whom. These are my disclosures. Heart failure is a global pandemic. In other words, more than 60 million patients worldwide have heart failure. Back in 2016, heart failure was the underlying cause in almost 80,000 deaths in the United States. Despite guideline recommendations, heart failure therapy is not currently optimized. These are the data from the CHAMP Heart Failure Registry. Approximately 2/3 of patients with heart failure are not treated with the neurohormonal inhibitors, although there is no contraindication. More than 50% of patients with heart failure suffer from heart failure with preserved ejection fraction. This proportion is significantly increasing. No clinical improvement therapies are available to reduce heart failure outcomes until recently. And the data from the Framingham study show that the proportion of heart failure patients with HFpEF has significantly increased over time. Patients with HFpEF are very sick patients, and this slide shows that HFpEF patients experience similar or worse limitations with daily activities compared with heart failure patients with reduced ejection fraction. In addition, the proportion of hospitalized patients with HFpEF has increased over time, while the mortality is more or less similar between patients with HFpEF and HFrEF. Having all this in mind, let's discuss the role of SGLT2 inhibitors in patients with heart failure. Let's review the data. Starting from the DAPA-HF, this was a randomized placebo-controlled trial. 4,700 patients were enrolled, and Professor McMurray et al. Examined the efficacy and safety of dapagliflozin in patients with heart failure with reduced ejection fraction. Patients were randomized in two groups, DAPA 10 milligrams versus placebo. Primary endpoint, time to first occurrence of any of the components of the composite cardiovascular death or hospitalization for heart failure or urgent heart failure visit. Among the inclusion criteria, symptomatic patients with heart failure, left ventricular ejection fraction less than 40%, eGFR more than 30, and the most important exclusion criteria were type 1 diabetes mellitus and eGFR less than 30. This study showed that the use of dapagliflozin led to 26% relative risk reduction regarding the primary endpoint, which was statistically significant as early as day 28, and the event curve separated early and continued to diverge over time. Regarding the effects of dapagliflozin on worsening heart failure and mortality, dapagliflozin showed very good results regarding cardiovascular death and all-cause mortality. Patients on dapagliflozin experienced significantly less adverse events. Regarding the subgroup analysis, the efficacy of dapagliflozin was consistent across the pre-specified subgroups, type 2 diabetes mellitus, baseline eGFR, MRA use, New York Heart Association class, left ventricular ejection fraction, NT-proBNP, sex, race, and others. As far as the safety outcomes, no significant differences between the two groups. Diabetic ketoacidosis presented in only 3 patients in the dapagliflozin group. Let's move on to DELIVER, which was a randomized controlled trial in patients with heart failure and mildly reduced or preserved ejection fraction. 6,200 patients were enrolled with left ventricular ejection fraction more than 40 and symptomatic heart failure, eGFR more than 25. This study showed the efficacy and the safety of dapagliflozin, also in the preserved ejection fraction, 18% relative risk reduction, which was statistically significant as early as day 13. Regarding the components of the primary endpoint, dapagliflozin reduced the combined endpoint of cardiovascular death or worsening heart failure, but it didn't reduce cardiovascular death. Secondary endpoints, dapagliflozin reduced the endpoint of worsening heart failure and cardiovascular death as long as the change in cancer's quality of life. Safety, no differences between the two groups. Data from the pooled analysis, which showed that dapagliflozin demonstrated benefit in the composite of cardiovascular death or heart failure hospitalization across the range of left ventricular ejection fraction. And let's see the numbers. 15% relative risk reduction for cardiovascular death, 10% relative risk reduction for all-cause death, and almost 30% for total hospitalizations for heart failure. Let's move on to EMPEROR-Reduced, which was a phase 3 randomized double-blind placebo-controlled trial, empagliflozin versus placebo. Inclusion criteria similar to the DAPA-HF, symptomatic patients with reduced ejection fraction and increased natriuretic peptides, exclusion criteria, eGFR less than 20. In this analysis, in this study, the primary endpoint was significantly lower in the empagliflozin group compared to placebo, 25% relative risk reduction. No difference between groups regarding the rates of hypotension, hypovolemia, and hypoglycemia. No cases of ketoacidosis. Emperor preserved. This was the study in patients with heart failure and preserved ejection fraction, composite primary endpoint, time to first event or adjudicated cardiovascular death or adjudicated heart failure hospitalization. Similar results, relative risk reduction 21% in the Emperor preserved in favor of empagliflozin compared to placebo. Emperor pooled left ventricular ejection fraction did not impact the effect of EMPA on cardiovascular death or first heart failure hospitalization. Key secondary endpoints, Emperor preserved 27% relative risk reduction for first or recurrent heart failure hospitalizations, and consistent renal protection across the left ventricular ejection fraction range. Safety, no major differences between empagliflozin and placebo. Empagliflozin reduced hyperkalemia events while it didn't affect hypokalemia events. EMPALS complements the Emperor trials in examining the effect of EMPA across the whole left ventricular ejection fraction spectrum. Very important study, which included patients with de novo and acute decompensated chronic heart failure, patients with diabetes type 2 and without diabetes, and patients with reduced and preserved ejection fraction. Main exclusion criteria, eGFR less than 20, type 1 diabetes mellitus. In order to take the drug, the patient should be stabilized. In other words, this was defined as systolic blood pressure more than 100 millimeters of mercury, no increase in IV diuretic dose, no IV vasodilators, or no IV inotropic drugs for 24 hours. This study showed the efficacy of empagliflozin. It was 36 more likely to experience a clinical benefit a patient on empagliflozin than those who received placebo. The clinical benefit was consistent across all pre-specified subgroups. Summary of adverse events, no major differences between the two study groups. This is our experience from our center. A small study, real-world data from 200 separate patients, unique patients, which showed that the in-hospital use of SGLT2 was associated with almost 60% lower risk for heart failure or for death, all-cause mortality, or heart failure risk hospitalization. Do we have data in patients after MI? Yes, we have. We have the IMPACT MI, which was designed to investigate the efficacy and safety of EMPA in patients after MI. The composite primary endpoint was time to first heart failure hospitalization or all-cause mortality. Patients were included with STEMI or non-STEMI, and these were high-risk patients for heart failure. In other words, patients with signs or symptoms of congestion and newly developed left ventricular ejection fraction less than 45%. No significant difference regarding the primary endpoint in this study. We have also the DAPA-MI, which was a randomized registry-based study, which included 4,000 patients with STEMI and non-STEMI, without diabetes mellitus or heart failure, eGFR more than 20. This study was positive, but the results were driven mainly by the cardiometabolic effects of the drug. So this probably is the central illustration of this presentation, which shows the practical considerations for the use of SGLT2 inhibitors in heart failure. A consideration might be a genital myocytic infection, mycotic infections, which are more common among women. Most cases are treatable with topical or single-dose oral antifungal therapy. Regarding hypoglycemia, this is rare, especially in non-diabetic patients. Regarding diabetic ketoacidosis, it is rare, may occur at lower than normal glucose levels, and we must be very suspicious in these patients, especially in patients who are on insulin. Lower extremity amputations, there was a signal observed in 1 or 2 trials of canagliflozin, but not with other therapies. Guidelines, SGLT2 inhibitors are recommended in patients with type 2 diabetes mellitus at risk of cardiovascular events to reduce hospitalization for heart failure, major cardiovascular events, and stage renal dysfunction and cardiovascular death, class A, level A. And the 2021 guidelines would recommend the use of dapagliflozin or epagliflozin for patients with HFrEF, heart failure with mid-range and low and preserved ejection fraction. Based on the data from the STRONG HF study, an intensive strategy of initiation and rapid titration of evidence-based treatment, including SGLT2, before discharge and during frequent and careful follow-up visits in the first 6 weeks following a heart failure hospitalization is recommended. Last slide, the future. This is an interesting study recently published in JACC, propensity matching analysis showing that the use of the SGLT2 inhibitors in patients with ATTR amyloidosis was associated with better outcomes, lower all-cause mortality, lower cardiovascular mortality, lower heart failure hospitalization compared to the control group. Dear colleagues, what would be an ideal heart failure therapy to implement? 1 pill once per day with no dose titration, which substantially improves survival and prevents hospitalization, which improves quality of life, which is well-tolerated and safe, which does not reduce blood pressure, no adverse kidney effects, affordable and accessible. Thank you very much.
Well, congratulations for the excellent presentation. I think there's no question that these agents, they are here to stay and they improve prognosis, they decrease mortality. However, just one question about the beneficial effect, especially in high ejection fractions. It seems that there's an attenuation of the benefit in these ejection fractions, and this you showed also very well the Emperor preserved and other studies. And why is this a problem for treating these patients with agents? And is it possible to have a specific cutoff point above which it's not the beneficial effect is not so important?
Thank you very much for this excellent question. This is really an evidence from the studies. And we know that SGLT2 inhibitors work in the range up to 60%, and probably they don't work in the range between 60 and 65, but the number of patients in these studies was very low. That's why the statistical significance could not be reached. In addition, in this trial, there is a concern that they were included patients with other kinds of cardiomyopathy, such as hypertrophic or amyloidosis, the problem with the HFpEF definition.
Is there any question, please? Can you repeat this with the mic, please, because we didn't...
Yes, hello. Dr. Xanthopoulos, I would like to ask, have you consider any other route than the oral route as a form of pharmacotherapy for heart failure patients? Because you mentioned in your last slide that, of course, ideally the dose would be just once a day. I'm just wondering if, if there's any consideration of another route other than the oral. Thank you.
Okay, thank you very much. I think that the Perot's route is the easiest way to give a patient a treatment. So, having in mind that the use of SGLT2 is via Perot's, I think that this is good.
Professor Naka.
Thank you, Dr. Sampopoulos, for a very nice talk. Would you consider the renal protection effects that these medications have? As I consider it's a very important beneficial effect of the medications. Do you think it's a class effect, or there may be a differential effect between the two agents that we have available?
Okay, you mean, thank you very much, Professor Naka, for this excellent question. You mean the difference that we observed regarding the two studies with EMPA and DAPA? There is a meta-analysis which showed that the effect is consistent in both drugs. So there is no difference.
You think it's probably a class effect
yeah.
of the medications? Oh, okay.
By the way, after your excellent question, just to mention that the nephrology, the renal community didn't have such a strong study to show such very good results in terms of mortality. And similarly, this is also for the diabetics. So if there is no other question from the audience, we can proceed to the...
So let's proceed to the second presentation. Our next speaker is Dr. Grigoris Yamouzis, an associate professor of cardiology at the University of Thessaly. He will present, the title of presentation is Obesity and Heart Failure, Therapeutic Challenges and Current Treatment Options.
Tell me if you can hear me and if you can see my slides, please. Can you hear me?
Yeah, yes, Dr. Yamouzis, we hear you. You can proceed.
Okay, thank you so much. So I would like to thank the organizing committee for the kind invitation, and I would deal with a subject which is very hot right now, actually the challenges that we face in obese heart failure patients. Those are my disclosures. I will start with a female patient, 74 years old. She presents to the emergency room with shortness of breath. She has a history of hypertension. She is obese with a BMI of 36. She has type 2 diabetes mellitus. Resting ECG is sinus rhythm with heart rate of 110. Uncontrolled, as you see, blood pressure. Echo with indices of hypertrophy and increased left ventricular, left atrial volume index with preserved ejection fraction. And we have an NT-proBNP quite low of 240. So what are the challenges here? First challenge is regarding diagnosis. And why do we say that? Because heart failure symptoms like shortness of breath or fatigue have a broader definition in diagnosis, including deconditioning, including obesity, COPD, anemia, aging, and all these kind of disorders. And obesity may actually mask the traditional heart failure symptomatology. On the one hand, if we take the HFpEF score, which consists of 6 weighted predictive variables, we can see that obesity confers actually with a heavy weight in the pretest probability of having HFpEF, and that's why it takes 2 points. So in that particular patient, we will have 2 points for obesity, 1 for hypertension, and 1 for aging. And the pretest probability is 75%. So we will need something more like echocardiogram or the NT-proBNP. And in that case, we have also diagnostic pitfalls with BNP values, especially in obese patients. In contrast with aging, CKD, atrial fibrillation, or ARNIs, where all the kind of values of BNPs and especially NT-proBNP are increased, in obese patients, we can see that the higher the BMI, the lower the BNP. There are certain endopeptides that can catabolize BNP. So we have lower BNP values actually in obese patients. And just take 3 examples of 3 different patients that do have 100 picograms per ml of BNP. If we have a low BMI, the pretest probability of having a PEF is 22%. If we have a normal BMI, the pretest probability would be 35%. And if this particular patient has a high BMI, having 100 BNP leads to a pretest probability of 52%. And this is why many authors or researchers recommend using lower BNP cutoff values for threshold in obese patients. The second challenge is epidemiology. We know the epidemic of obesity. Actually, more than 2/3 of deaths related to high BMI are due to cardiovascular causes. And we know also that more than 80% of people with chronic artery disease are living with overweight or obesity, and more than 50% of people with heart failure do so. And what is the pathophysiology link between obesity and cardiovascular disease, and especially heart failure? Even in the absence of traditional risk factors like dyslipidemia or hypertension or type 2 diabetes, obesity through systemic inflammation with interleukin-6, TNF-alpha, interleukin-1b, or increased endothelial and platelet dysfunction or oxidative stress may promote cardiovascular disease and heart failure in particular. And we know that obesity also increases the risk of having heart failure, even, as I said, in the absence of metabolic abnormalities such as hypertension, diabetes, and hypertriglyceridemia. You can see that it doubles the probability of experiencing heart failure, and in the presence of those metabolic abnormalities, it may increase fourfold the probability of developing heart failure. What can we do about it is the question. The next challenge is exercise or diet in obese heart failure patients. Generally speaking, the effects of exercise on traditional risk factors are very beneficial. It can decrease by almost 20 to 30% all traditional risk factors for a CAD or heart failure. And this translates in significant reduction in coronary heart disease, in stroke, and in developing heart failure or decreasing the class of heart failure in patients with established heart failure. How does exercise benefits cardiovascular disease? Due to different pathophysiology pathways like anti-atherosclerotic or anti-ischemic, anti-arrhythmic, and the antithrombotic effects that has in certain pathways. So exercise in heart failure in particular, and particularly in obese patients, even in low intensity, as you can see with the gray exercise protocols, even so more in high intensity protocols, can promote cardiomyogenesis, as you see in the upper slide, or even angiogenesis with dense capillary, as you see down, in as fast as 1 week after protocols of exercise. Also, exercise induces activation and proliferation of endogenous cardiac stem and progenitor cells so fast as 2 weeks of exercise, and also circulating endothelial progenitor cells in heart failure patients. After 8 weeks of exercise, you can see that they are increased, and if you have a deconditioning for 8 weeks, this will return back to the baseline values. Very similarly, exercise training in heart failure promotes anti-inflammatory effects, since it can decrease after training. You see 6-month training, the values of interleukin-6, TNF-alpha, and interleukin-1b in those patients that are exercised. And very importantly, exercise induces the different distribution of skeletal muscle. We know that the beneficial type is fiber 1, which is the endurance type in skeletal muscle, and not the fiber 2, which is strength but not endurance. After exercise, you can see that patients with heart failure will increase their fiber type 1 skeletal muscle as opposed to control. And this translates in reverse remodeling in those patients, since they will decrease their end diastolic volume, they will decrease their end systolic volume, and ultimately they will increase their ejection fraction. That would lead to a better exercise duration and better functional class, as we know from every trial that examined the effects of exercise training in heart failure population. Challenge number 4 is weight loss. We know that not only with exercise, but also with diet. So if you have a calorie restriction in those patients, diet can induce the same weight loss as exercise in patients with heart failure, and particularly in HFpEF. We can do that with surgery-induced weight loss, but this is actually an intervention and a high-risk intervention in patients. However, we know that even with bariatric surgery, when you lose weight, you can have reverse remodeling after 3 or 6 months, and you can have a reduction in rehospitalization in patients with failure, or a reduction in the risk of developing HFpEF in normal or hypertensive patients. And why to do that when we can do that with oral pills like tirzepatide? You see that this is the drug that can reduce weight in almost all patients by 20 to 25%. And we now have oral GLP-1 receptor agonists that can do the same, but they can barely reach 10 to 15% weight loss. So do we have trials that can predict which patients will benefit from this? Yes, we do have. Actually, STEP-FEPF had patients both with diabetes and with no diabetes. So this was a randomized double-blind placebo-controlled multi-center trial with the goal to evaluate the effect of semaglutide versus placebo in patients with the obesity phenotype of HFpEF, regardless of the presence of type 2 diabetes. With regard to physical function, body weight, inflammation, and symptomatology. Almost 500 patients were randomized in a one-to-one fashion to receiving semaglutide once weekly or placebo once weekly. And the efficacy, as you can see here, was very good for semaglutide, since, first of all, it reduced almost 15% the weight of our obese heart failure patients. And with that, it significantly improved their quality of life, as quantified by the Kansas City Cardiomyopathy Questionnaire in 52 weeks, as you can see. And it significantly increased the functional class due to the duration that they could walk. So this is data for their mean 6-minute walk distance. Semaglutide significantly increased the distance that those people could walk. And if we put in a win ratio with a composite of all-cause mortality or heart failure hospitalization or quality of life or 6-minute walk distance, you can see that semaglutide statistically significantly increased the win ratio for this population. Importantly, GLP-1 receptor agonists reduced systemic inflammation, as you can see here, quantified by the reduction in high sensitivity CRP in those patients, and also reduced the stress parameters like NT-proBNP, and also increased the quality of life, as I already said, with the Kansas City Questionnaire. This was not intention to treat, actually, and it was not a secondary endpoint, but when we make a sub-analysis, you can see that there is a significant trend to reduce rehospitalizations in patients receiving semaglutide. In terms of safety, semaglutide demonstrated a lower rate of serious adverse effect, but a higher rate of adverse event, especially gastrointestinal disorders that could lead to discontinuation of the drug compared to placebo. However, the cardiac and respiratory adverse effect was significantly less frequent with semaglutide. So, in terms of efficacy, semaglutide was superior to placebo, quality of life, body weight reduction, sigmoid stress, inflammation, and hierarchical composite endpoint. And in terms of safety, overall, the profile was consistent with previous experience for semaglutide. So I would like to stress the following things: obesity in patients with failure, both HFrEF and HFpEF, poses multiple diagnostic, epidemiological, and therapeutic challenges. Exercise-induced weight loss in heart failure is feasible and safe and exerts large improvements in cardiopulmonary exercise, symptoms, quality of life, and rehospitalization for heart failure. Very similarly, weight loss has shown beneficial effects on cardiac remodeling, peak VO2, quality of life, and probably reduces heart failure hospitalization rates. And GLP-1 receptor agonists such as semaglutide are both efficacious and safe and are here to stay in the obese HFpEF phenotype. Thank you so much for your attention.
Dr. Yamouzis, thank you very much for your excellent presentation. I would like to ask a question, if it's possible, regarding the high cardiac output heart failure. Is it a different entity related to the heart failure with the preserved ejection fraction? Is it more often seen in the patients that are obese, and it's the same approach that we use?
When obesity is the causative factor, yes, it's the same. However, you can have high output in beriberi disease, in hypothyroidism, in pregnancy. So this is a different part of thing regarding weight loss. So I cannot put all these things together.
Okay, thank you very much. Is there any other questions from the audience? So we can proceed.
Thank you. Okay, let's move on to the next presenter. Is the well-known Professor Milionis from the University of Ioannina. He will tell us a few things about the novel lipid-lowering therapies to reduce the risk of first or recurrent stroke.
Thank you, Chairman. And I would like to thank you for asking me to contribute to this significant event and honor me with your hospitality and your friendship. Thank you very much. And I will try to discuss very briefly the possible role of novel lipid-lowering therapies in the prevention of the first and recurrent stroke. So we all know that the mainstay of anti-lipid therapy are the statins. The statins actually are the most commonly used drugs to lower LDL cholesterol. Our group has showed that in the primary prevention, statins reduce the risk of stroke by 30%. But what is more is that the most benefit is seen in those individuals in the primary prevention with multiple cardiovascular risk factors, such those in the heart protection study, and especially in subjects with diabetes, as in the CARDS trial with atorvastatin. In the European Stroke Organization, we had the chance to show that in patients experiencing a stroke, statins at high doses may reduce the risk of a future stroke by 12%, but they reduce the risk of an ischemic stroke by 20%, and this is the benefit for any cardiovascular event in the future. And the benefit in reducing strokes is double than that considering the intracerebral hemorrhage. So what about the novel interventions which are used on top of lifestyle modification measures and statins? I would like to show you the bempedoic acid and the PCSK9 targeted therapy. Bempedoic acid is not yet available in Greece and I think in Cyprus too. It has the same pathological pathway to affect the LDL cholesterol, but it is activated only when it reaches the liver. So we're not going to anticipate any adverse effects from muscles or the brain. It reduces the LDL cholesterol by as much as 20 to 25%. Whereas the antibodies against the PCSK9, alirocumab and evolocumab, or the small interfering molecules, some mRNA molecules like inclisiran, which is silencing PCSK9, they decrease LDL cholesterol by as much as 50 to 60% from baseline. So we need combination therapy to reduce LDL and reduce further stroke. In a meta-regression analysis, we've shown that the lower the LDL levels we reach using statins as the basis of our treatment, the greater the reduction in the absolute risk of a future stroke. So we should aim for low levels of LDL cholesterol. And we need only 13 stroke patients to be treated with a statin plus ezetimibe in order to avoid one future stroke in the IMPROVE trial. By using evolocumab, it has been shown that we can get a 10% further decrease in the relative risk of stroke in patients who actually have not only cardiovascular disease, but a history of stroke too. And there is evidence with alirocumab that we can decrease the risk of stroke by 27% in those suffering an acute coronary event. The most benefit is seen in those with a baseline of LDL higher than 100 milligrams per dl, that is more than 2.5 millimoles per liter. And of course, the net benefit for stroke is about 10%. Our team has also showed that the benefit by using PCSK9 inhibitors refers to the ischemic strokes, that of atherothrombotic origin. And those who get the most benefit are those starting with an LDL higher than 2 millimoles per liter. So in the European Stroke Organization, again, we have showed that if we use combination therapy in patients suffering a stroke, we get about 20% less risk to have a recurrent stroke or a major cardiovascular event after the index event of stroke. So what about the new agents which target the PCSK9? We know from a pool analysis of the Orion studies with inclisiran that by using inclisiran we get a benefit in terms of reducing cardiovascular events, but we expect outcome trials in the future. The net benefit for stroke is about 14%, but this is not significant. And again, in about 3,700 patients, the net benefit of inclisiran is about 8 to 10%. And what about benzoic acid? This drug has been used in patients who are actually intolerant to statins. And in these patients, there is a benefit in reducing stroke by 15%, though not significant. And in this meta-analysis of about 17,000 patients, there is a net benefit of 16%. And what about omega-3 fatty acids? We know that triglyceride-rich lipoproteins increase the risk of ischemic heart disease and peripheral artery disease, but they also increase the risk of stroke by 30%. When icosapent ethyl was used in the REDUCE-IT trial in subjects who received statins, and they were actually patients with cardiovascular disease, in these patients, there was a decrease in the risk of stroke by 30%. And this again referred to patients experiencing an ischemic stroke. And of course, there was no increase in the intracerebral hemorrhage or bleeding. But if we reach very low levels of LDL cholesterol, is there really a risk of increasing the likelihood to suffer an intracranial bleeding? A meta-analysis has shown that with the current evidence, by lowering LDL to less than 55 milligrams per dl, there is not any increase in the risk of suffering an intracranial bleeding. And the major issue is, of course, the adherence to treatment in stroke patients. It has been shown that patients who actually stay on treatment to reduce their LDL and they attain these low levels of LDL cholesterol, these patients are the ones to get the most benefit in terms of secondary prevention. And which is the therapeutic algorithm we could suggest. In line with the European Atherosclerosis Society and the European Cardiology Society, the Hellenic Atherosclerosis Society and the Hellenic Stroke Organization recommends that we should optimize these patients to receive the maximal tolerated statin treatment. Then, if the LDL target of less than 55 milligrams per DL is not reached, we should actually add ezetimibe and consider the use of a PCSK9 inhibitor. But what about the novel drugs I just mentioned? I think that if there is something like intolerance to treatment with statins, we should consider using as monotherapy a PCSK9 inhibitor or modifier, or bempedoic acid when this agent is available, either alone or with the use of ezetimibe. And of course, in subjects with triglyceride levels higher, I would suggest higher than 150 milligrams per DL, we could keep in mind or consider the use of icosapent ethyl as an add-on therapy. Thank you. In time?
Perfect.
I did my best.
Well, thank you for the excellent presentation. I think everybody agrees that these agents, they have a future and they are helping to prevent, especially for secondary prevention, as this is our topic. I just have a small comment. It seems, and I will speak as a cardiologist, it seems that there is a discrepancy between the way that we treat patients for secondary prevention in terms of coronary artery disease and what the neurologist or the internal medicine they do for stroke. And the secondary prevention for the neurologist and for a lot of them, not all of them, they refer the patients to internal medicine, and they seem that they are not are so aware about the need to and the targets for blood pressure and sugar and of course LDL. So this is, I just want a comment from you. And my second comment is about the implementation of all these limits, all these algorithms that you perfectly mentioned. You know very well in Greece you cannot get accept that you cannot have the PCSK9 if you don't have an LDL above 70 or 55 if in case you have diabetes mellitus. So it's a little bit unfair for some patients not to go for the guidelines that they exist in the other world.
I'll try to be brief and keep it short. So in primary prevention, I think that the internists and the cardiologists have actually are the ones who should act to prevent the first event. So we'd actually aim for blood pressure lowering, for keeping measures who actually modify our lifestyle, but keep in mind that we should lower LDL cholesterol according to the global risk of a cardiovascular event. This applies to stroke too, that this is for primary prevention for coronary heart disease, peripheral artery disease, but stroke too. In the secondary prevention, I think that the brain is as noble as the heart. So we should aim for low levels of LDL cholesterol. And there is evidence that if we could go actually to less than 70 milligrams per DL in the LDL cholesterol levels, we actually help these patients not suffer not just a stroke, but a cardiovascular event afterwards. So we should be very careful and cautious to actually discharge these patients with a statin or a statin plus ezetimibe and consider them for a PCSK9 inhibitor afterwards, as you mentioned, because these patients not only have a stroke as a first event, but they actually may have a coronary artery disease event prior to that or previously, so they are candidates to receive a PCSK9 inhibitor afterwards. And of course, in Greece, the patient should have a level of LDL cholesterol higher than 100 milligrams per DL to be a candidate to receive a PCSK9 inhibitor. But if there are two events, like a TIA and acute coronary syndrome, he may be a candidate after an LDL level higher than 70 milligrams per DL.
Is there any question from the audience? Yes, please.
Thank you. Great talk. And as a cardiologist, it's helpful to see from the other side. Is there any data about the relative risk reduction or guidelines with dementia reduction?
Sorry?
The end pathway of multiple strokes will be for some dementia. Is there any data about the relative risk reduction, or is there guidance?
For dementia, you mean dementia? Yeah. I think that we should take this out when we discuss about lowering LDL cholesterol to lower than 55 milligrams per DL. There is not such an issue with statins, and there is not such an issue with drugs like PCSK9 inhibitors. We have evidence with Ebbinghaus and trials that actually targeted patients who attained a very low LDL cholesterol level and they didn't have any cognitive impairment.
But is there benefit for reduction in dementia?
I wouldn't suggest that. I think they do not affect, either improve or deteriorate the cognitive function.
One more question here.
Hello, similar question. What about studies that show that lowering LDL might produce less psychological well-being and cognitive decline?
The cognitive decline?
Yes, it's similar, exactly. What do we do about those studies? That's what I'm asking.
The studies which?
That show that there is cognitive decline.
There is not such a study, there was just observational studies. And if you go with the AHA, for example, recommendation, you will see that in randomized controlled studies or in big studies, the observational ones, there is not such an issue as cognitive decline by using statins and by achieving very low LDL cholesterol levels.
So you think there might be flawed in methodology?
I think so.
Thank you.
So let's, one last question. Let's say that, which is the lowest LDL level that would ask you?
Not for stroke patients.
For stroke patients. Let's say that someone...
I gave, I think I did my best to persuade neurologists in the European Stroke Organization and try to persuade him to lower LDL to less than 55 milligrams per DL. I failed. They just want LDL lower than 70 milligrams per DL. I'm okay with that because most evidence is with this level. Although we have some evidence that we may go lower. So 70 milligrams per DL is okay for now for patients with a stroke. If you ask me for patients with coronary artery disease, I would go to 0 because we are born with 20 milligrams per DL. And then we are the only mammal to take our LDL to as high as 200 milligrams per DL.
Thank you so much. If there's now another question, let's proceed.
So, for our next presentation, let's introduce Dr. Katerina Naka, Professor of Cardiology and Head of the Heart Failure Unit at the University Hospital Foianina. The title of the presentation will be Advanced Heart Failure, an approach to the multiple challenging needs of an increasing patient population.
Thank you. Thank you for inviting me for the second time in this very interesting event in Cyprus, a beloved place of mine. And thanks for having so much heart failure in the program. That is, I think, the fourth in a row. Especially after Professor Starling's
talk on advanced heart failure. I think it's very important to emphasize that I will talk about everything else that we do in Greece on advanced heart failure, apart from LVADs, because simply we don't do almost any LVADs, or a very, very small amount. So it's nice that we can share our experiences. Well, advanced heart failure comes usually to the end of a long journey, if the patient is lucky, deteriorating, having multiple hospitalizations. Professor Starling mentioned it as stage D, severe symptoms and signs despite the maximally tolerated heart failure treatment, and comes to a stage that needs advanced heart failure therapies, and we can discuss what these are. We had a serious problem, I think, defining advanced heart failure via different scientific societies, and in Europe anyways, we use this definition that came up in the guidelines of 2021, where we should have all these 4 criteria, despite the patient being on optimal medical therapy. We should have severe and persistent symptoms, quite advanced symptoms, NYHA class 3 or 4, severe cardiac dysfunction, and it's not only very low ejection fraction of the left ventricle, but other abnormalities as well, as you can see here. And the patient should have multiple episodes of decompensation that sometimes is congestion, sometimes is low cardiac output, which is even worse. And they should also suffer from severe impairment of exercise capacities. And this is, to me, the weakest criteria, because, well, even in Greece, we don't have many centers that do a 6-minute walk test, and we have even fewer centers that do ergospirometry. So it's, I think that's the weakest criterion of all. We all agree that it has an abysmal prognosis with a very low 1-year survival. Even in comparison with very bad cancers. And patients and health systems suffer from a high number of heart failure hospitalizations that happen again and again, and we cannot do something to stop it. Despite all this, the Europeans, the ESC, has put in this BEASY treatment algorithm, advanced heart failure in the spotlight, and suggested that for selected patients with advanced heart failure, they should be referred for heart transplantation, long-term mechanical circulatory support, either as bridge to transplant or bridge to candidacy, or even as destination therapy, something that I think doesn't happen in Greece, or probably doesn't happen in Cyprus either. They gave us a treatment algorithm depending on the Intermax profile to send the patient or use short-term mechanical circulatory support, or refer them for advanced therapies to see whether they're candidates. And we should really identify them quite early in this process, offer them whatever risk stratification we can, and refer them as early as possible to the Advanced Heart Failure Center to see what they can do with them. Well, this is the ideal picture. Let's see what happens in Greece. In Greece, we still haven't clearly defined what is an Advanced Heart Failure Center and which centers we have in our country. Our hospital fulfills all the criteria. We do as much as we can do. And the only thing that we don't do is what the tertiary center does. We only have one tertiary center, probably is the only shared between Greece and Cyprus as well, is the Onassis Cardiac Surgery Center. We do all the other stuff, apart from offering heart transplant and offering long-term mechanical circulatory support for any reason. So what we can do in all other aspects of advanced heart failure, since we're not doing these 2 very important things. We have to exclude and treat reversible causes of heart failure that contribute to the advanced stage. revascularize ischemia, offer vascular heart disease treatment, offer treatment for arrhythmias, and this is a crucial thing in Greece, since ablation for ventricular tachycardia nowadays is offered in a very few EP centers, mostly in the private sector. Identify systemic conditions that may need other special treatments, and alcohol or substance abuse, stopping those may lead to improvement of cardiac function. At the same time, we have to ensure that a patient is treated with maximally tolerated treatment. This is quite difficult because most of these patients do not tolerate important heart failure saving treatments. And we should also think of devices, the appropriate devices, and the list is quite extensive. It's not just the 4 or 5 bigs, but we have to think of all this armamentarium. The CRT, cardiac resynchronization therapy, to me is part of the optimal medical treatment. If the patient is an appropriate candidate, they should all have CRT at any stage, hoping to improve the patient. CCM, cardiac modulation, is also another option that is rarely used in our countries. And it's also another therapeutic goal to me is mitral valve. The transcatheter repair of the mitral valve is an important therapeutic target for patients who have moderate or severe mitral regurgitation and are at an advanced stage of heart failure, using either the mitral clip or the Pascal device. And I'm sure more mitral and tricuspid valve interventions will come in the near future, even in our countries, to serve these patients. For those who, despite all the above, remain asymptomatic, we still have or should think of palliative care, inotropic agents, and other more complex decongestion strategies. Especially for patients who are not candidates for the really advanced therapies, these are the only tools that we have to make them feel better. For the candidates, for patients who are real candidates for advanced therapy, we should really push their referral to the only tertiary center. Regarding inotropes, and I don't know, Americans don't like that, but we use them a lot. It's only dobutamine and norepinephrine that we really use in these patients. But we also use levosimendan as well. Few studies have shown that in intermittent infusion leads to less symptoms, less natriuretic peptides, improved quantity of life, and that's quality of life, and that's what we have. We even consider ambulatory inotropes that have led to have shown a small improvement in functional capacity, although they don't have an impact on survival. Diuretics that internists don't like, we use them a lot, and you can use mega doses, as you see here. And we would really like to have subcutaneous furosemide, because what we do now in our practice, we use intermittent, scheduled intermittent infusion of diuretics for a few hours in selected patients. We even use renal replacement therapy for patients who are really sick and you are in the unit, simply because ultrafiltration is has been given a very low level of recommendation, and given also the cost, the penetration in our clinical practice is very low. Temporary or short-term MCS devices to buy time for stabilizing the patient, improvement their perfusion, improvement the virological status, or sometimes improving their right ventricle and give them an opportunity to become candidates for LVADs and heart transplants. We have a limited armamentarium in general, and in Greece we are stuck with intra-aortic balloon pump, and very few centers have also used Impella for that purpose. We shouldn't forget end-of-life care for patients who are not candidates for any of the above, and they're still admitted in cardiology departments in our hospitals. But don't forget, End-of-life care is not synonymous to palliative care. Palliative care is a concept that doesn't exist in Greece, especially in cardiology. We don't have that specialty, and that's a thing that we should really think about and consider pushing in our governments to think about integrating palliative care in our hospitals and in our practices. It's an approach that should improve the quality of life of our patients and the families, and heart failure is a life-threatening illness. It reduces the suffering of the pain, of the symptoms, and it's not just talking to the patient. It should really be addressed to all patients with advanced heart failure, even those who are candidates for the advanced therapies, but especially for those who are not. We don't have this nice structure of primary, secondary palliative care. We don't have any palliative care. It would offer an opportunity to the patients and their families, educate not just on heart failure, but on the trajectory of heart failure and the nature of the illness and how the clinical course of the disease will go, understand the decisions that we'll have to take in the course of the disease. We still treat the patients with the proper heart failure treatment, but we also take care of other symptoms that are very distressing. And physical exercise, as Professor Yamuzi said before, is an important component of the palliative care that we should offer to the patients. Coming back now to Greece, the number of advanced heart failure patients in the country is not known. It is based, we estimate on a basis of all data coming from the US, that we may have up to 8,000 patients with advanced heart failure, and honestly, we don't know how many of these are truly candidates for advanced heart failure therapies. And it's a pity, because we cannot go to the government, to the state, and say that we need so many LVADs or so many heart transplants. We don't have a leverage. We did a small study in my department for only 3 months, and we've seen that of the patients who were admitted with acute heart failure in the department over a period of 3 months, 30% of those were actually fulfilling their criteria for advanced heart failure. And out of those 20 patients, there was only 1 patient who was eligible for advanced heart failure therapies. We treated all the others with diuretics, with inotropes, as I said. We gave them TAVIs when they needed. We gave them mitra clips. We even put them in intermittent infusion programs of inotropes or diuretics. And there was only 1 patient, as I said, that was found to be a candidate. And I'm proud to say that this patient was actually transplanted, and she's doing well after a year. I'm sorry for the Greek. This is the flyer of the working group of heart failure of the Hellenic Cardiac Society. That we decided very recently to put up a registry, a Hellenic Advanced Heart Failure Registry, to actually find out how many advanced heart failure patients are treated for the next 6 months in our hospitals. Almost all hospitals in Greece, at least the advanced heart failure centers, have agreed to participate. We will find the patients who are admitted or those who are followed up in our outpatient clinics. We will spend 6 months enrolling them, and we'll follow them up very easily for another 6 months, hoping to give this very, very important number to our Hellenic Cardiac Society and probably to our government, how many LVADs we need, how much palliative care we should offer to patients admitted not in internal medicine departments, but in cardiology departments, even in advanced hospitals. And these are my take-home messages. Advanced chronic heart failure is the final, let's say, stage, with very poor survival and a great number of hospitalizations. It is very important to increase the awareness of the cardiological community of this severe condition. We should use all the available treatments in an appropriate way, because we may not offer them quantity of life, but we should offer them symptom relief and improved quality of life. And I think we need urgently data on this important group of patients in order to design a country-specific plan so that advanced heart failure therapies are made available for more patients in our country. And I hope Cyprus centers will also be part of this and will agree to participate in this national effort. Thank you very much for your attention.
Professor Naka, congratulations for your excellent presentation. Because we have the pressure of the time, I will not make any comments. I don't know if there are any questions.
I believe that you did not mention in your conclusions one of the most important findings in your study. And for me, it was very important to demonstrate that approximately half of your patients with advanced heart failure have mid-range or preserved ejection fraction. That means that this shows once again, and you reproduced the two epidemiological studies of the Mayo Clinic that showed exactly the same things and the same prognosis, and the ejection fraction should be removed from the definition of advanced heart failure. Once again, congratulations for the presentation.
Well, it's important to say that low ejection fraction below 30% is one of the components of the severe cardiac dysfunction. There is also the right ventricular failure. It's also the persistent symptoms with HFpEF and severe valvular heart disease. Professor Starling wants to have say something.
Thank you for the presentation. I would just give my own opinion that advanced heart failure is agnostic to ejection fraction. So I have two questions. One, would you comment on the use of digoxin in advanced heart failure? And number two, I don't know if omecamtiv mecarbil from Galactic HF is available in your country, but there will be a new clinical trial launched soon for severe heart failure.
Yeah, thank you for that. I completely agree with yourself and Professor Triposkiadis about the ejection fraction. For omecamtiv, I think we were top recruiters in Greece in the Galactic heart failure trial because we obviously are interested in that population, and our patients on omecamtiv did really, really well, given the poor prognosis. So we were all waiting for a company to take over the medication, but that hasn't happened. So the medication is not, I think it's not available anywhere in the world at the moment, unfortunately to me. The second, the other question on digoxin, I'm actually a fan of digoxin. We use it a lot because of that population, but it's difficult nowadays to train your physicians, even the cardiologists, to know how to use digoxin safely. So this is my only worry. If my team starts digoxin, we should follow the patient up. It's not as with warfarin. We have a big problem. These medications have left our clinical practice, and we have to use them very safely. But I'm a big fan in these patients, especially those whose right ventricle. Patients who, with a right ventricular dysfunction, they are at great need of digoxin.
We have any other questions? No. So, thank you very much, Professor Naka. We can proceed.
So let's move on to the last presenter. It's Professor Farmakis from Matihon Hospital in Athens, Greece. He's a well-known physician for cardio-oncology, so he will give us his lecture on atrial fibrillation in cancer, latest advances in therapy. Dr. Hormakis, I think he's ready, he's online, and we are ready to enjoy him.
Hello, can you hear me?
We should change the slides.
You can see my screen, my slides. I'm sharing my screen now. Is this okay?
Yeah, no, it's okay, yeah. You can start, Dimitri.
Okay. Thank you very much. Thank you for the kind invitation. For this important conference. And I'm really sorry that I wasn't able to be there. It was for a technical reason. My flight was somehow delayed, so I lost it, and I couldn't be there, and I really regret this. I hope I will join you all next year. So atrial fibrillation in cancer, my disclosures. We know that arrhythmias are common among patients with cancer, and they usually result from the interaction among three factors: patient with any coexisting cardiovascular disease or cardiovascular or cardiometabolic risk factors, cancer that may affect the cardiovascular system, and more commonly through systemic derangements, and also cancer therapy that may lead to arrhythmias either directly, like through QT prolongation, or indirectly by causing other forms of cardiotoxicity that will result in arrhythmias. So atrial fibrillation in cancer, we published this 10 years ago in JACC, and since then there has been a lot of interest in this association between cancer and atrial fibrillation, and there are different factors that may lead to atrial fibrillation from cancer, but not to forget also the common risk factors such as aging and comorbidities that can lead to both conditions. Recent epidemiological data supports this bidirectional, let's say, association. This comes from the Netherlands. This is the most recent big epidemiological study on this association. And it says that patients with cancer have an increased prevalence and incidence of atrial fibrillation, and vice versa. Patients with atrial fibrillation seem also to have an increased prevalence of cancer and also an increased incidence of cancer. And both conditions worsen the prognosis of the other in terms of all-cause mortality. So we know that cancer in therapy can lead to atrial fibrillation. What about the opposite, whether AF can lead to cancer? Of course, this is largely dependent upon this detection bias, which means that the patient with atrial fibrillation is started on an anticoagulant, and anticoagulant makes a tumor that has not been yet diagnosed to bleed, which is a common thing to say, but maybe there are other explanations for this reciprocal association between the two conditions, and of course the common risk factors that lead to both. Now, treating AF in cancer patients in terms of rate control, cardioversion, ablation, and so on is done like in non-cancer patients, but with two important things that we need to consider. First, the prognosis of cancer and the stage of cancer, and second, any drug-to-drug interactions with under cancer therapy. Otherwise, we do it as in non-cancer patients. The difficulty, the most challenging thing, is the anticoagulation for atrial fibrillation in cancer patients. And the most important thing in terms of anticoagulation is this question, whether we're talking about active cancer or non-active cancer, because in non-active patients, we do the same as in non-cancer patients. But what about active cancer patients? Those are the challenging ones. So active cancer is a cancer that has been recently diagnosed within 6 months, a malignant disease that is currently or very recently treated with anti-cancer therapies, and also an advanced, recurrent, metastatic, inoperable, or end-stage malignant condition. This is the definition of active cancer. Now, anticoagulation may be particularly challenging in this active cancer population. So what are the challenges involved? First of all, cancer is by itself an hypercoagulable state. The malignant cells may activate the coagulation and inhibit fibrinolysis either directly or indirectly through inflammation, systemic inflammation, endothelial dysfunction, and through also the cancer therapy. So thrombosis is the second leading cause of patients with cancer after cancer itself. So about 10% of cancer patients actually die of thrombosis. And there are several risk factors related to thrombosis in patients with cancer, patient-related factors like age, gender, obesity, and so on, or vascular cardiometabolic comorbidities, cancer-related factors such as the type of cancer, the histological type, like adenocarcinomas, the treatment of cancer in terms of either chemotherapy like platinum compounds, or targeted therapies like VEGF inhibitors, or surgery or central catheters for long bed rest, and so on. On the other hand, patients with cancer may also have a high bleeding risk, either related to cancer site, like intracranial lesions, or intraluminal lesions, or hematologic malignancies causing coagulation abnormalities and low platelet counts, and also cancer therapy that it may also very frequently lead to thrombocytopenia. And we know from large epidemiological studies that patients with AF and cancer have a higher bleeding risk, particularly for major bleeding, compared to those who have AF but without cancer. So cancer is both a procoagulant state, increasing the risk of thrombosis, but also a bleeding tendency that may lead to increased bleeding risk. What about the performance scores that we use in AF? There has been an update, as you know, in the atrial fibrillation guidelines. The HASBET score for major bleeding was abandoned, and the CHA2DS2-VAS score was shortened to CHA2DS2-VA. But still, these scores have not been tested in patients with cancer. Actually, they may not be accurate in patients with cancer. What about pharmacokinetics? Particularly regarding the oral medications, pharmacokinetics are modified in terms of absorption, distribution, metabolization, and excretion. So gastrointestinal complications are common, like nausea, vomiting, mucositis, diarrhea, and these complications may actually affect the absorption and the availability of the drugs in the circulation that are taken orally. On the other hand, there is a common prevalence of kidney disease in patients with cancer. Up to 70% of cancer patients, particularly those with renal cancer, may have significant renal dysfunction that is related to mortality. And oral dysfunction is also important for the coagulation, and this is a table showing which of the new oral anticoagulants, of the direct oral anticoagulants, they are not new anymore, can be used according to eGFR. And eGFR actually may change a lot in the course of active cancer. And finally, drug-to-drug interactions. They are very, very common in patients with cancer. About half of patients in this study had at least one significant drug-to-drug interaction between anti-cancer agents and other drugs taken for other indications. And this is also another important thing that we need to consider. This is a table showing significant interactions between the four DOAC and some very common anti-cancer agents such as doxorubicin, anthracycline, targeted agents such as imatinib or sunitinib, agents used for prostate cancer, hormonal therapies like abiraterone. And this is also a thing that should be considered when we are deciding on anticoagulation in patients with a cancer. So the cardiologists really think, according to this European study, that there are significant challenges for anticoagulation in active cancer. And this leads to the underprescription of anticoagulation in patients with atrial fibrillation and concomitant cancer. In this registry, Blitz AF registry from 6 countries, only half of patients with cancer were initially prescribed a DOAC for atrial fibrillation, while up to 10 to 20% of patients were not taking any anticoagulation, despite having similar platelet counts or similar hemoglobin level or similar bleeding history or bleeding risk or similar stage of cancer. So they're not only the restrictions or the limitations of increased bleeding risk, but the general, let's say, fear of prescribing anticoagulations in patients with cancer. What evidence we have regarding anticoagulation for atrial fibrillation in patients with cancer, and I will talk only for atrial fibrillation now because we have a lot of evidence for venous thromboembolism, but I'm not tackling this topic. So these are the seminal DOAC trials in patients with general atrial fibrillation, and according to these trials, DOACs, the direct oral anticoagulants, are now the mainstay for the vast majority of patients with atrial fibrillation. What about cancer patients? Well, in cancer, there are no randomized trials for stroke or systemic embolization prevention in patients with atrial fibrillation, but there are some sub-analysis of those seminal DOAC trials, like from Rocket AF, from Aristotle with rivaroxaban and apixaban, respectively, and Engage for endoxaban. All these studies collectively, sub-studies, secondary analysis, collectively have shown that there is practically no difference between patients with cancer, patients without cancer in terms of efficacy and safety of DOAC versus warfarin. But if we take a closer look at those secondary analyses, we will see that those studies didn't include actually any patient with or very, very few patients with active malignancies, because this is usually an exclusion criteria in clinical trials in cardiovascular medicine. So in Rocket AF, less than 0.1% of patients had metastatic cancer. Aristotle, 0.8% only had a cancer diagnosis or treatment within 1 year, and the same was also true for Engage AF. So not really any evidence from randomized controlled trials. What about observational studies? That was Aristophanes study was a large observational study, patients with cancer and atrial fibrillation, and most of those patients enrolled here. There were recent use according to the security system, social security system of an anti-cancer agent. So these patients could be considered as having active cancer, and what this study showed that DOAC had variable, let's say, efficacy and safety versus warfarin patients with cancer. Apixaban had a clear was clearly better than warfarin, and in DOAC versus DOAC in comparisons, apixaban again was better than the bigatran in efficacy and better than rivaroxaban in safety, but these are observational data. This is not a randomized clinical trial. So according to this evidence, what are the recommendations for anticoagulation for atrial fibrillation patients with cancer? So we have published this, we'll propose this acronym TBIP several years ago, 4 or 5 years ago, saying that patients with cancer, with active cancer, need to be, the decision needs to be individualized or tailored according to their characteristics in terms of T, thromboembolic risk, B, bleeding, I, drug-to-drug interactions, and P, patient preferences, of course. And actually this approach, this TBIP consideration, needs to be periodically reassessed, as both the thromboembolic risk and also the bleeding risk can be different from time to time, can be fluctuating a lot in the course. was actually endorsed by the guidelines that we published 2 years ago in 2022. So this TBIP should be used for the individually tailoring of the anticoagulation therapy, and there will be patients with a very, very high bleeding risk, as patients with very recent or active major bleeding, or those with evolving intracranial lesions, or those with platelet counts below 25,000, for whom we should not prescribe any anticoagulation. And for the rest of the patients, we can consider direct oral anticoagulants, with some exceptions, like patients with an unoperated intraluminal cancer in the GI or GU tract, with significant gastrointestinal comorbidities or toxicity, those with a platelet count between 25 and 50,000, where just a half dose of low molecular heparin can be used, and also those with significant interactions between DOAC and anti-cancer agents. And for these patients, we should consider low molecular weight heparins as an alternative to DOACs, as long as DOACs cannot be used. Of course, there are no evidence on low molecular weight heparins in terms of prevention of stroke or systemic embolization in patients with cancer, but in patients with atrial fibrillation, but it's the best thing that we have for these patients. And an important thing is also we should not forget screening for atrial fibrillation whenever we encounter a patient with cancer. And also today there are a lot of devices, wearable and portable devices that patient can use for the screening of atrial fibrillation. So this is my final slide summarizing this presentation. So atrial fibrillation are related. Cancer with cancer is related with cancer. Cancer may lead to atrial fibrillation through different mechanisms, and also the two conditions are linked with common risk factors like aging and cardiometabolic comorbidities. When these two conditions come together, we should consider rhythm or rate control or other treatment strategies, as in non-cancer patients, considering the cancer prognosis and the drug-to-drug interactions. And regarding anticoagulation, we need this TBIP approach in order to individually tailor our anticoagulation decisions. And with this, I stop my presentation. I want to remind you or to inform you that the European Society of Cardiology launches the very first dedicated cardio-oncology congress. This will happen in June 25 in Florence, Italy. And in this congress, we will discuss a lot of interesting topics, I think, including anticoagulation for active cancer. And if you want to have more information and be more actively involved in the European initiatives regarding cardio-oncology, you may just enroll in the ESC Council of Cardio-Oncology, in which the membership is completely free. So thank you for your attention.
Thank you for the excellent presentation. So it seems that there's a strong interaction between atrial fibrillation and cancer, common risk factors, agents for cancer that can cause atrial fibrillation, and the arrhythmic drugs can cause cancer. And we have also the antiplatelets, the antithrombotics that can reveal the cancer. Unfortunately, Dr. Farmakis, we don't have time for a discussion. Thank you again, and we have to proceed to the next speaker. I think it's, please don't leave the room. Professor Triposkiadis will give us a special lecture about heart failure, congestion in heart failure from bench to bedside.
Okay, thank you, Mr. Chairman. Once again, I would like my friend Ioannis Patrikos for the kind invitation in the organizing committee. And I would like to start my presentation with No, okay. I'm not going to need the slides for the first 2 minutes, okay? So, before the beginning of the speech, I would like to make two clarifications. The first one is that congestion is agnostic to left ventricular ejection fraction, like the severity of heart failure and maybe like the treatment of heart failure. And the second is that we use this term, and despite the fact that we don't know a lot of things about congestion, and especially I'm going to try to convince you that there are also problems in the treatment of congestion. Is it okay with the slides now? Is it okay with the slides? Okay. So, now, we all know that heart failure starts with a heart lesion, and then which is followed by neurohormonal activation, and then by water and sodium retention. Something that maybe we don't realize is that, as you can see here, the volume of circulating blood increases from 4 liters, 4 liters to 6 liters, but what increases much more is the interstitial, the water and the sodium in the interstitial compartment, and we should keep in mind that. And what also should we keep in mind that there are two main mechanisms of congestion, the fast one and the slow one. And what's the fast one? Now, I would like to remind you that the capacity of the splanchnic veins is high, and blood is accumulated in the splanchnic veins, and it stagnates there without elevating the pressure. This is called the unstressed blood volume. Okay, but the problem there is that the splanchnic veins have a lot of sympathetic innervation, and when there are stressors like emotions or increase in blood pressure, then the sympathetic nervous system stimulates the splanchnic veins, and blood is shifted to the circulation, to the other veins and the arteries, and this is the way that it works, that the fast pathway works. Now, what about the slow pathway? Other stressors, chronic stressors, that acting through the kidney, okay, the result in the accumulations of sodium and water through the kidney, okay? So we have these two main mechanisms. Now let's see the basis for the treatment of congestion in chronic heart failure. Now, it's based on this assumption that, first of all, the slow pathway works in this way. First of all, we have an increase in pressures, and then we have autonomic adaptation, a change in thoracic impedance, and then an increase in weight, symptomatology, and eventually we end up in the clinic. So, as you can see in this slide, we have a time period to intervene so that we can interrupt this course. And this is the basis that the investigators implanted sensors in the pulmonary arteries that monitor the pressure there, and with telemonitoring. And one of these devices is CardioMEMS, was implanted in the pulmonary artery, measure the pressures, and through telemonitoring we could measure the pressure and intervene at an early stage prior to the development of symptoms. And as you can see here, the results of the champion trial, which was the first trial that used this device, it's called CardioMEMS, showed that in the intervention arm, that those that carried the device had less hospitalizations, and also sorry, this is the study. And so the combined endpoint of hospitalization and mortality was lowered. And the results of champion trial were confirmed in a recent trial, monitor exactly the same trial with patients in New York Heart Association Class 3, regardless of the left ventricular ejection fraction. And as you can see here, what happened in the patients that carried the device compared with the patients that had standard treatment without the device, did not carry the device, had left heart failure hospitalization, and if I can see it well here, they had a greater reduction in pulmonary pressure and NT-proBNP. So it seems that this device works, but today, every time before I give a speech, I watch the literature, and you know, the whole previous treatment of the patients was based on the elevation of pressures in the pulmonary artery. And now my friend Randy Starling, in a recent editorial that he made, as you can see here, he argues that this is not enough, and through telemonitoring, we have to check a lot of things, like besides the pressure, and you can see here the heart rate, the weight, the oxygen, and stuff like that. In other words, pressure is not by itself, it's useful. It's probably the best that we have nowadays. But we have to realize the disadvantages. And I think that we can see it here. This slide, published in the European Journal of Heart Failure, I believe it's very important. With the investigators, actually, it's only one investigator that uses a technique that measures the blood volume with radioisotopes, which is, in my opinion, the most accurate technique. What he did, he measured the central venous pressure, you see it there, and the pulmonary artery capillary wedge pressure in patients euvolemic and hypervolemic. And you realize that, of course, the pressures were higher in those that were hypervolemic. But what you see here in the slides, when you correlate the blood volume with the pressure, the correlation is poor. And that means that you cannot use the pressure as a gold standard. I mean, we do it now, but we have to know the disadvantages. And this one is a very big disadvantage. And from the same group, and I like that very much, I learned a lot of things. But before we discuss the things, we are going to discuss recent evidence suggesting that the diuretics that we use to treat congestions are not without adverse effects, and we have to be very careful. And these findings are from a recent study in Glasgow that approximately 200,000 patients were divided in those with heart failure treated with or not treated with diuretics, and with patients or individuals without heart failure, treated or not treated with diuretics. And you can see here that patients without heart failure, this one, treated with diuretics, let's say for hypertension or something like that, had the same prognosis with patients with heart failure not treated with diuretics. So we have to be very careful to diagnose heart failure, and then to diagnose congestion, and then to give diuretics, because if the indication is not correct, this is not going to be to the benefit of our patient. And now we go to the algorithm. And, well, I have to admit that every time that I see the position statements and the guys that tell me what to do, I always check if they are right or wrong. And as you can see here, okay, they say, okay, you check the sodium in urine after 2 hours, and then you check the urine volume, and then accordingly you see what we're going to do with diuretics. And you see here this one, I like that very much, that to measure the sodium in the urine after 2 hours. Now, you are not going to believe it, but the studies that showed that this may be useful were conducted 2 or 3 years later. And this is based on expert opinion. And what I would like to tell you is, and this is the problem of the recent medicine, that statistical significance equals clinical significance, which is totally wrong. You can have a p-value that has nothing to do with clinical significance, okay? So let's go to a problem that we have when we try to decongest the patient, which is diuretic resistance. And now I think there is some evidence that we can prevent it by using, let's say, acetazolamide at the beginning, not in the patient that has diuretic resistance. But still, we have to use thiazide, metolazone, when we have a problem. Now, what about dapagliflozin? I'm not going to discuss it because if you don't give dapagliflozin or an SGLT2 inhibitor in a patient with heart failure, is wrong. So all patients, in the absence of contraindications, should be treated with an SGLT2 inhibitor. And let's see how these agents, acetazolamide and thiazides that increase diuresis, help us with diuretic resistance. And now you can see here, this is the S-shaped curve of diuretic, of every diuretic, which is here is in heart failure, and if you give the agent, it's shifted to the left. When you give acetazolamide, the threshold of urine production is lowered, and then supposedly checking the urine, the sodium in urine, you can adjust the dose of the diuretic, and you only use the thiazide here, you increase the diuretic ceiling, and this is the way that we can treat it. So we have to decongest our patient, and we have the clinical tools, the average score, the NT-proBNP and the BNP, and I would say that imaging now help us, and the collapsibility index of the inferior vena cava, and also something which is helpful is lung ultrasound. When the patient leaves the hospital, has to have less than 30 lines. But we have to share. You have to see some things. If I ask you, when we give the diuretic, what do we reduce? Which volume, which fluid we reduce? And what you see here is what you do is we reduce the fluid which are accumulated in the tissue and not the fluid of the circulation. And this is something that we have to consider. And something that I find very interesting, and this is from a study that measured the blood volume prior to discharge of patients with heart failure. And what you can see here is impressive, is exactly the opposite of what we believe. Those that are decongested, but they have an expansion of blood volume, they do better. And also, by the same investigator, if the mass of the blood cells is increased during discharge after decongestion, the patient is doing better. I cannot explain this to you, but we cannot ignore these findings. And when we want to study something, we have to use the best means to do it. And okay, now we have pressure. It's probably the best we have, but it's not good. Okay? So, the other thing is, and it's a recommendation to all of you, as you can see, this is a very recent study published this year that shows that if we ablate the sympathetic nerves that innervate the splanchnic veins, and we avoid the shift of blood from the splanchnic veins to the circulation, that's a good thing. And because we can reduce the pulmonary pressure, and the patient is doing right, and these are the preliminary results. Before leaving the room, I read a study published 2 days ago in JAMA Cardiology, which shows that the results of this study, when the whole population was evaluated, were negative. But I didn't have the time to include it because it was published the day before yesterday, and I noticed that today. So the best thing in heart failure is to prevent congestion and to fix the heart as much as we can. And we do it with the classical agents, the ACE inhibitor, the sacubitril valsartan, SGLT2, and the beta blockers. And we have to consider that removing fluid with diuretics is palliative for the patient, and it's not going to prolong his life. And now the conclusion is that the homeostasis of fluid volume is something very complex, and we have to remember that we have blood and we have fluids both the intravascular and the interstitial compartments. Something which is very important is that, okay, the elevation of pressure is useful, but it should not be, it's currently the best we have, but we have to find something better because it's not the gold standard, and we have to realize, and that's the reason why the weight of the patients who are congested many times does not change. It does not change because we have the shift of blood from the splanchnic vein, from the splanchnic veins to the circulation, and this one, the targeted volume redistribution. The last one, I'm not so sure today that is useful and is going to help us. Maybe we find another technique, things are going to get better. Thank you very much.
Thank you, Professor Teroskiadis, for this didactic and comprehensive presentation. It seems like our target will be decongesting the patient, but in order to do that in a right way, we need to understand the mechanisms, exactly how the blood volume distributed and the mechanism on a cellular level. But on the other hand, I like what you mentioned, that the way to go forward is to utilize technology as well and new devices to get a better monitoring with regards to what the mechanism might be involved into and target our therapy, because the only thing that we all knew so far is that congestion, dyspnea, shortness of breath, orthopnea, PND give diuretic and the game is over, but it's not the case.
Okay. Well, you know something, I think that heart failure is in the wrong way. and is driven to a dead end. And it is, in my opinion, it's silly to discuss about treatment with ejection fraction that is our own creation. I have nothing against the ejection fraction. I am against trying to classify a complex disease as heart failure with a single index. And what I would like to the young fellows that are going to leave this room is, it is by itself wrong to say treatment of HFpEF. You cannot say treatment of pneumonias, because HFpEF includes hypertrophic cardiomyopathy, hypertensive heart failure, aortic stenosis. They are, some of them are the genetic forms of HFpEF. So the best thing to do, in my opinion, is understand the mechanism, and in every patient with heart failure, try to find the cause, and first eliminate the cause, and then treat the syndrome, which includes congestion. But if we can prevent congestion with the other agents that are not diuretics, then I believe it's the best thing that we can do, but it's not so easy.
Great. Reclassification of the nomenclature and definition of heart failure is needed, at least as Professor Naga has shown on the different stages of advanced heart failure. It makes more sense than anything else. Just getting the ejection fraction a little bit on the side than what we used to have it so far.
If I ask somebody here, what's the difference between HFpEF and hypertensive heart failure? Can anybody tell me? The answer is no. And in all the studies, the vast majority of patients suffer from hypertension. And if you reach the epidemiological data, you see that the two important causes are hypertension and coronary artery disease in all epidemiologic studies. And all the other comorbidities that are supposed to be present in heart failure, they are non-existent.
Thank you so much for this excellent presentation. As we're running late, we need to proceed to our next keynote speaker, which is on hybrid. I'm profoundly honored to have Professor Christodoulos Stefanadis, Professor of Cardiology, all known to us and the old generation with all his contribution to the profession, but most importantly to the academia. Professor Stefanadis, welcome.
Yes, good afternoon. Can you hear me?
Yes, we can.
Yes.
And we can see your slides as well.
Thank you, Chairman, for this kind invitation, kind introduction. I would like to thank the organizers to be member and honorable member in this important meeting. The first question, is aging a normal phenomenon or a disease? Another question is, how many years can a human being live? Probably there is no known limit to how long humans can live, according to Nature editorial in 2018. Another question is aging a treatable disease? Back to the past, Aristotle found that hot and wet must be dominant in the living organs, and warm, humid climate in conductive to longevity. Egyptians alchemists try to find the elixir of longevity, but unsuccessfully, as you know. This is King David. His servants suggest in old age, his servant suggested let us find for the king a young virgin woman to take care of him, keep him warm, and sleep by his side. This is the virgin lady named Avisang. The miracle was done, and the king was revived. In 1498, the French aristocrat named Diane de Poitiers consumed and drink gold to maintain her youth. This probably is the reason contributed to her death at the age of 66, probably due to gold toxicity. Another lady, Elizabeth Bathory from Hungary, drank blood from young women in order to keep herself young and beautiful. In 1820, Brown Shigart hypothesized that male hormone is the elixir of immortality. For this purpose, he used fluid from the testes of pigs and dogs. And based in this hypothesis, Voronov transplanted monkey testes into a man. What about Mediterranean diet and exercise? 25th century before the Mediterranean diet, Pythagoras of Samos proposed a similar diet to the Mediterranean, and he concluded the consumption of fruits, vegetables, and grains probably is the way to be for the longevity. Hippocrates, in this field, he was the first to recognize the need of a balanced diet and exercise, and the fact that different age has different needs. It's amazing, 400 years ago, Joseph Georgiridis, he was an archbishop of Samos, found in the island of Icaria, is a common thing to see people of 100 years old. And the most important things on this island are the air and the water, both so healthy that the people live long. He published these observations in a book in London. Recently, 5 regions in the world are characterized as a place of the people with longevity. One of them in Icaria, an island, as you know, in the Aegean Sea near the border of Turkey. In our institution, we organized the Icaria study, a study to find any factor related to longevity. Briefly, our findings. We detected moderate factors like Mediterranean diet, calorie restrictions, exercise, anti-inflammatory diet. Also, coffee consumption, Greek coffee consumption, fish consumption, physical activity, moderate or high activity, and sexual health, plus to testosterone levels in serum. Also, modified factors are siesta, sleep duration, the ideal duration of sleep we found that is 7 hours a day, marital life, low depression rates, and low stress level. About the non-modified modified factors, favorable genetic background play a role, and favorable environmental conditions. Here we found the role of low dose of gamma radiation. Atrial aging mediates, as you know, the effect of TNFA and ACE polymorphisms on mental health in elderly individuals. And also we published our data regarding these factors. And that means the vascular age is related to the genetic background or elderly individual. Regarding the arterial endothelium longevity, during the endothelial function, as measured by in elderly individuals in ICARIA study, was better than in the control group. And interestingly, during the pandemic, the serious case of COVID-19 disease that recorded in ICARIA were few and comparatively much less than the rest of the country, probably because the healthy endothelium. Increased aortic stability, data from this study, from ICARIA study, detected by echocardiography, is associated with an increased probability of better cognitive functioning, a higher MMSE score in advanced age in both sexes. And about the telomeres, is a very interesting topic. We know that short telomeres length is associated with many diseases of aging that accelerate cardiovascular aging and increase cardiovascular mortality. And this is a very interesting finding. The northern and northwestern part of the island of ICARIA, here is island of ICARIA, presents higher levels of gamma radiation, annual dose 0.20 to 3.31 millisieverts. According to Hellenic Statistical Service, the percent of elderly more than 90 years old is higher in this part, is the northern part. And from our results of ICARIA study, we found that residents in the northern part of the island had increased longevity compared to individuals of other parts of the island. Probably the very low dose of gamma radiation play a role. So in this study, we concluded that longevity is related to diet, to exercise, to psychological factors, to habits, to genetics, and to environmental factors. But what about the future in this topic, in longevity? The length of telomere as a biomarker shows a clear correlation with age. This is established knowledge from bibliography. The question is, can a home test predict the biological age? At-home testing, evaluating the length of telomeres, is already in the market, and probably a more reliable similar test may reveal insight about the biological age. About the future, 30 years, after 30 years, the number of people more than 60 years old will have increased fivefold, with significant implications for health economics. Suggestions say to delay the disease of old age and promote longevity that should be explored. Probably diets that involve avoidance of food intake, drugs that inhibit the growth hormone insulin growth factor 1, and drugs that inhibit the TOR S6K metabolic pathway. Drug that regulate specific protein sirtuins, drug that inhibit the inflammatory process, and taking metformin. Metformin, I remind you that it is a very established active drug in diabetes, to treat diabetes. And in the far future, Mr. Chairman, dear colleagues, in area of metamedicine, probably by using personalized big data, we are able to understand individual genetic profiles and predict their lifespan. Using a single drop of blood from the patient to diagnose potential disease. And the final question is, how many years can a human being live? Here is a creature that lives more than 400 years. This is the Greenland shark. And the question is, what about humans in the future? Probably by the new technology, new diagnostic techniques, a new treat disease related to longevity probably play a role in order to increase the lifespan of individual of our planet. Thank you for your attention.
Professor Stefanadis, thank you for this innovative lecture. Quite interesting. There's so much to think about and philosophize on, but we would like to thank you just to the late on the schedule. Unfortunately, we cannot make further discussion or questions with regards to your lecture. We thank you, and thanks for this inspirational kind of approach, and give us a kind of a hopeful message that the environment might more or less regulate the cell cycle that eventually will not and inevitably will not be shortened but delayed maybe.
Thank you, Mr. Chairman. Yes, I agree.
Thank you so much. Have a great afternoon, and hopefully next year we'll have you with us in person. Thank you. Thank you. Thank you. We move on to the next chair, Professor Abramidis.
Yeah, we will move on we would like to call upon the chairs Dr. Panagiotis Abramites and Dr. Aris Anastasaki.
Good afternoon, everyone. We've got a fascinating next set of lectures. Yes. And we're starting with the first of the two lectures. It's a great pleasure to invite Professor Dr. Amanda Varnava to speak. Dr. Varnava is a consultant cardiologist, Chief of Service for Cardiology at Imperial. She undertook her medical training at Oxford and Barts. She went on to train in cardiology at the Brompton Hospital, St. George's, and she's a consultant and honorary lecturer at Imperial. She's the lead for inherited cardiac conditions with a busy service of 2,000 patients. She also has a specialist interest in sports cardiology, in pregnancy, and runs a specialist pregnancy and heart disease service. She has extensive experience in managing patients with heart failure. Now, as we all know, syncope is a very difficult and very challenging symptom for us cardiologists. And we look forward to the genetics of syncope. Dr. Barnaba.
Thank you very much indeed, and Kalispera, and it's a huge honour to be here. Thank you to Yanis and the committee. So my talk is about syncope, and the context to this is that around half of the population will suffer a loss of consciousness at some point in their lifetime. For most, it is a benign, not a life-threatening condition. However, for around 50% of those who die suddenly, their warning is a syncope, a loss of consciousness. And that gives us the window and opportunity to try and protect against sudden death. Understanding the genetic basis can unlock some of that understanding. So today I will discuss some of the mechanisms of syncope. I'll talk about the genetic basis for syncope, the purpose of genetic testing, and in brief outline how to get a gene test. So transient loss of consciousness has multiple causes, of which the biggest cause is a vasovagal or a cardiac cause. So if we're thinking about which direction to refer patients, always think cardiology rather than neurology, and statistics back this up. Of syncope, the majority is vasovagal, or so-called benign. And around 20% of all TLOC causes are due to a cardiac or arrhythmic cause. Seizure is just 10%, and other rare causes such as metabolic derangement can indeed cause TLOC too. There are genetic traits linked to the mode of syncope. The non-cardiac syncope, the reflex or vasovagal syncope, does likely have some genetic traits to it. The arrhythmic syncope has well-described genetic basis, both in terms of the channelopathies, the structurally normal heart with electrical problems of the heart, and the cardiomyopathies, where there are structural abnormalities. We now clearly understand that there is a genetic basis to conduction disease for some patients, particularly those presenting with conduction disease before the age of 60. Lightly touching on vasovagal syncope and why we think there may be a genetic trait for some patients, studies have looked at several factors that might hint at this. The absence of syncope in other animals. We know of no other animal that has a vasovagal episode. It only affects a minority of the population. There are persistent clinical and physiological phenotypes, and there is no apparent other cause. We know that vasovagal syncope can affect 65% of affected relatives, compared to 35% prevalence in the general population. That already hints, therefore, to a genetic trait. We also understand that there are some sex differences between the inheritance of this trait. Mothers with vasovagal syncope can pass on the trait to either son or daughter, where men or fathers only to their sons. There is an association between the neurohumoral axis and receptors for this and vasovagal syncope. This is on a GWAS basis, and we do not yet know thoroughly enough of genetic trait to test. In terms of arrhythmogenic syncope, we now know that there are many channelopathies and a few cardiomyopathies with a clear genetic basis for which we can now test. Within the channelopathies, it is usually a disruption or a mutation or loss of function of one of the channels in the cell membrane, often the sodium or potassium. These causes syndromes such as long QT syndrome, Brugada syndrome, catecholaminergic CPVT, and short QT. If I just touch on long QT syndrome as an example of how understanding genetics can actually help us both in the diagnosis, but also in the risk stratification management of patients according to their genotype. For many, unfortunately, the genotype will not be known when you're making the first decision about whether to offer an individual defibrillator. However, if you have got time in the workup, then understanding the genetic basis can help us triage the risk and the best management. For instance, long QT syndrome 1 has the basis of a mutation in KCNQ1. And we know that this can be particularly triggered by exercise and swimming, whereas type 2 is often by abrupt awakening during the night and often triggered by an alarm. So we will counsel our patients not to be awoken by a sudden alarm. For long QT3, this sadly often happens during sleep, but the management can differ according to these different genotypes. For instance, beta blockers in long QT1 and 2, and more often the use now of flecainide in long QT3. So understanding the genetics has a big impact on the management of these patients. And if we have a patient with known long QT syndrome, we can find the gene in nearly 3/4 of individuals. We now more recently understand the genetic basis for progressive cardiac conduction disease, both in terms of progressive cardiac conduction disease and atrial standstill and sick sinus syndrome. There are many different genes now known associated, and I won't go through all of these, but one of the commoner ones is SCN5A, which has a multi-purpose use, as it were. It can underlie conduction disease and isolated conduction disease, but it can be associated in 25% of patients with Brugada syndrome. We know that there are certain phenotypes that might give us a link to what the genotype may be. For instance, if you have syncope in an individual with ASD, they might harbor a mutation in the TBX5 gene, and if you find that gene, they have a high risk of sudden death, and you may want to offer them a defibrillator. Similarly, for instance, the laminopathies. If there is a suspicion of a young individual with premature conduction disease found to have a lamin gene, then you would have a very low threshold for considering a defibrillator. If we go back to the gene of SCN5A, it codes for the sodium channel. It can manifest both according to the specific mutation with Brugada syndrome, an electrical problem leading to a higher risk of ventricular fibrillation and sudden death. It can also, according to different mutations, cause long QT3 syndrome, progressive cardiac conditions, conduction disorders, atrial standstill, and actually increasingly recognized as a cause of premature and familial atrial fibrillation. The newly named multifocal ectopic Purkinje-related premature contractions, which is a mouthful, even if English is your first language, is probably now describing a certain group of patients with idiopathic ventricular fibrillation. And it's good to be able to get rid of the idiopathic tag for many patients who don't really like the idea that we don't yet understand their condition. If we find the SCN5A gene, it helps us on the pathway for us to understand and the patients to understand better their condition. If we think about the genetic basis of cardiomyopathies, there are the hypertrophic cardiomyopathy group, the arrhythmogenic cardiomyopathy, and the dilated. And the genes that code for some of these conditions can, like in Brugada and atrial standstill, if according to the mutation, cause hypertrophic cardiomyopathy or dilated cardiomyopathy, such as the myosin heavy chain. The next question is why to gene test? I've touched on the fact that it will help us make a diagnosis. It will help us on risk stratification, and I will come to that. It can help in the wider aspects of family planning and future therapies, which I believe are now on the near horizon. So why to gene test? Well, certainly in the UK, there are criteria that are available for us now to offer gene testing, but to help in diagnosis is not one of them. I think it's really important to understand that genetics is not black and white. There is grey and uncertainty. So if you're already uncertain about the diagnosis, adding to that uncertainty with a variant of uncertain significance in gene testing will not help. So I think it is not that useful in making a diagnosis. However, if you have a patient with a long QT ECG and it is borderline of whether this is drug-induced or not, I think that is a reasonable case to add genetics in to help in the diagnosis. We often think about whether an individual may have so-called athlete's heart or hypertrophic cardiomyopathy. And again, in that kind of situation, where there is the gray zone, a thickness of the heart muscle, let's say 15 millimeters, that might lean you towards the disease rather than athletic adaptation, again, gene testing may be helpful. But perhaps, and certainly more frequently, we use it for risk stratification. In terms of the algorithms used for risk stratification on long QT syndrome, genetics is not the absolute arbiter, but it's one of them, alongside the absolute QT interval. In Brugada syndrome, individuals harboring a gene are deemed at higher risk. And now, with the new ESC guidance in management of arrhythmogenic cardiomyopathy, we now know that the threshold for offering a defibrillator will differ according to what your genotype is. So traditionally, if an individual had syncope and arrhythmogenic cardiomyopathy with good function, they would not necessarily be offered a defibrillator. However, the genotype will help in arbitering this. And certainly, even without syncope, if you harbor one of the higher risk genes, such as lamin, and you have just moderate impairment of your heart function, you will be considered at high risk and offered a defibrillator. So genotype really does matter in this setting. Why to gene test in terms of family planning? We know that it is useful in diagnosing family members, but there are 3 points in which family planning may be altered according to whether you know the gene. Families or couples can use it at birth. They can use it in utero to make decisions, but perhaps more importantly and increasingly, they are using it for pre-implantation genetic testing. This commits the couple to IVF, but does allow them to select our embryos, mostly with a very lethal mutation that has impacted the family already with multiple sudden deaths. The next, and perhaps increasingly exciting reason to use gene testing is for future therapies. And these futures are actually now for many different diseases. Currently, we really manage a lot of our conditions by symptom management only. For certain conditions, such as Fabry's disease, we're preventing symptoms with enzyme replacement according to what the gene defect is. But we're hoping with new therapies to actually prevent the disease. So with the microdystrophin gene, we are now enabling gene therapy as a way of managing individuals with muscular dystrophy. There are FDA-approved therapies for the treatment of amyloidosis. And increasingly, but not yet in practice, we're thinking about using CRISPR gene editing therapies for gene editing and gene modification. In the UK, the British Heart Foundation, which is one of our largest medical charities, put out a competition to attract bids for a very large investment, a single one-off investment that was being offered across all aspects of cardiology. And it was the inherited cardiac conditions and the cardiomyopathies and gene therapy that attracted that big award. Now, genetic testing across Europe is not universally available. And if we look at why this is not yet being undertaken, it has various reasons, including lack of reimbursement and the lack of an awareness. And I'm hoping that this last cause and the no perceived added value reason for not offering gene testing will certainly be not apparent as we move forward through the next few years. How to gene test varies according, of course, to each nation. But what is fundamental in the provision of gene testing is appropriate genetic counseling by trained individuals with robust links to bioinformatic teams. This is extremely important because we must not overdiagnose or underdiagnose in anything we do, and equally overinterpreting a variant of uncertain significance can lead to misery and poor outcomes. So, in summary, many of the causes of cardiac syncope have a genetic basis. Genetic testing following a syncopal episode with a thorough clinical workup may have a vital role in the diagnosis and risk management. Knowing the underlying genetic basis can help not just that individual, but their wider family. And gene therapies really are on the near horizon. Thank you.
Thank you, Dr. Varnava, especially for keeping to time. Maybe we'll have a chance for 1 or 2 questions. I'd like to start a comment mainly. It's not something that we undertake on our own in our clinic. I think I would emphasize the fact that you mentioned it's a team effort, and you need a genetic counselor who will counsel pre-genetic testing your patient or the family in front of you. So perhaps one question.
Well, first of all, thank you for this excellent presentation. You mentioned hypertrophic cardiomyopathy and dilated cardiomyopathy. And we know that there is a polygenic background, especially in dilated cardiomyopathy. However, in current guidelines, we don't hear something about the polygenic risk score, something that in masses at least can detect subjects at high risk for the development of dilated cardiomyopathy. Do you have a comment on that?
I think polygenic risk scores are definitely going to come in, not only for risk of getting the disease, but risk if you have the disease. Certainly things like Brugada were getting polygenic risk scores because we don't really understand the link between the SCM5A gene and the manifestation of the disease. I think obviously polygenic risks will definitely come in with more common conditions such as dilated cardiomyopathy, but they're not yet validated enough. So I think for now, just looking at that autosomal dominant gene and risk assessment, such as the RBM20 and the lamins versus the titans that are considered less at risk, is where we currently are.
Yes, okay. You first. You go on, yes.
Hi. I wanted to ask how sensitive and how specific is the genetic testing regarding, let's say, Brugada syndrome, since there's so many different gene variants present right now?
So really, we only consider one gene, the SCM5A gene, as being clearly linked or understood. There are rare SCN10 genes linked to Brugada, but the main one we look at is SCM5A, and we only find it in around 25% of individuals with Brugada. I think that Brugada syndrome will turn out to be quite heterogeneous, just like HCM, and that there will be different types of phenotypes, not just different genotypes. So I think our understanding of Brugada is really in the foothills of understanding now.
Dr. Varnava, you mentioned preimplantation diagnosis. Can you hear me well?
Sorry?
Can you hear me well?
Yes.
All right. You mentioned preimplantation diagnosis. My question is, if NHS provides this service free of charge, first, and second, what about the genetic testing? I mean, genetics testing is part of the public services or not?
Yes. So, I mean, in the UK, we were doing very, very little clinical genetic testing in the inherited cardiac conditions until 2019. In 2019, the NHS set up a national testing criteria. So we do have clear criteria. Someone with HCM has to be under 60 or have a clear family history. So we're trying to be quite robust about what the phenotype is, and kind of the age will guide us on how genetic it's likely to be. So from my practice, for instance, it's gone from only doing 2 or 3 genotypes a year to now doing 150, 200. So we're offering a lot of genetics. In terms of pre-implantation genetic testing, that is available and funded by the NHS, but I have to say there is an authority that approves it. And for most individuals, there's something just like DCM, they probably wouldn't be accepted. And indeed, in my experience, most individuals, most of the cardiomyopathies and even the channelopathies don't elect to go forward with pre-implantation genetic testing. Occasionally with the long QTs, and 1 or 2 have had approval.
Thank you.
Thank you, Dr. Varnava. Fascinating lecture. We could be here all day.
Okay, we can proceed. I have a problem with my... So I would like to introduce Dr. Paolo Madetu. Professor Paolo Madetu got the degree of medicine from the University of Sassari, Italy in 1976 with the title of Doctor in Medicine and Surgery. He completed his specialty in cardiology from the University of Sassari in 1980. Currently, he was the post of full professor. From the year 1980 to 2005, he served as a senior researcher with clinical appointment of consultant in Institute of Internal Medicine. His major interest is in genetics, cardiovascular degenerative medicine, tissue engineering, therapeutic angiogenesis, and gene therapy. The title of the current presentation is Shared Molecular, Cellular, and Environmental Hallmarks in Cardiovascular Disease and Cancer. Any place for drug repurposing? Please, Professor.
Okay, thank you very much. I hope you can hear me. First of all, I wanted to thank Johannes for a kind invitation, and I modified slightly my title and made it a little bit more simple. So I will focus on the next 20 minutes on drug repurposing for treatment of cardiac steatosis and ischemia. As you certainly know, the drug development process today is very complex, both technically and also in terms of cost, and require a series of validation from the preclinical stage to the clinical trials, phase 1, 2, and 3. And you can see here some example of how many compounds that are introduced in this stage of research then fail during the process of validation. For instance, if we consider just Alzheimer's disease, only 0.5% of compounds that are initially tested reach the clinical success. And the number of drugs that are also introduced into the market by regulatory agency are continuously diminishing. So the money invested in drug development is huge, but the outcome is very, very small. To overcome this kind of limitation, drug companies are trying to follow different strategies. And before I mention drug repurposing, I want also to mention that if the situation is challenging for industries, it's even more challenging for academic laboratories, because most of the research done in therapeutics by academic laboratories die very, very soon, or at least as a stage of early translation. So what is this other strategy that promises to solve or alleviate the problem? So it's called the drug repositioning or repurposing, and it's a process using a drug for, in general, used in the past with a different indication, and to repurpose the drug for a new indication. In general, it's based on already approved medicine or discarded compounds that show toxicity or were failed in previous trial. So what are advantages of repurposing an existing drug? First, it cuts the cost of research and reduce the time for generating a new compound, and eventually does not require phase 1 clinical trial. The potential for reuse, despite evidence of the adverse effect and failed efficacy in some indication, is another aspect of drug repurposing. So this is quite a complex slide, but I try to make easier to understand. So you can see that there's different methods to approach drug repurposing. Some are experimental in gray, and in blue some other, let's say, genetic approach. For instance, you can map a pathway and just consider pathways that can be targeted by a drug. Or you can eventually, as we heard before, consider the genetic background and genetic predisposition and eventually target a particular gene by a available drug. Or otherwise, you can eventually screen a large database and try to target the specific characteristic of the clinical characteristic or laboratory characteristic of specific population or a specific patient. This is actually another approach developed by Professor Mark Mercola, who basically is studying now iPS cell, differentiate iPS cell from patient to obtain carniocyte, fibroblast, or other kind of cell, and then try to test on disease cell like a model drugs that are already available. These are actually also involve a kind of iterative mechanism by which you can eventually refine the drug candidate, try to modify them chemically, and then repurpose in animal model before trying a clinical test, engage with a clinical trial. In addition to that, there are available mathematical models, for instance, these ones that you can find online, which are based on scoring algorithm to repurpose the drug. And in general, there are scores that are generated based on overlapping the compound with a specific target, or structure similarity, or disease compound disease scores. Another further approach is now using artificial intelligence. As you know, artificial intelligence is now proposed to solve a diagnostic problem, generating algorithm based on imaging, for instance, or diagnostic test, but it can be also used for developing new therapeutics, in particular for precision disease stratification for therapeutic purposes. In the case of drug repurposing, you can eventually try to use artificial intelligent algorithms to test first of all in models the drug, and then eventually test the best populations that they can take advantage from the repurposed drug. In our laboratory, we're using a more, let's say, biased method. We are focusing particularly on trying to condition vascular pericyte for increasing vascularization angiogenesis in ischemia. And I want to just use this cartoon generated by one of my fellows and published recently in JCI, in which I wish just to let you understand the complexity of the mechanism in which vascular pericytes are involved. These are mural cells that encapsulate the small vessel, but also cover nascent vascularization. And their establishment around the new vessel is essential to allow the neovascularization to be stable and efficient in terms of perfusion. Now, most of cardiovascular disease, including also risk factors like diabetes, are characterized by a detachment and instability of pericyte. So in our laboratory, we are trying to use, to repurpose drug to reinforce the feature of healthy pericyte and allow a more physiologic angiogenesis. In particular, we're interested about the compounds that inhibit the ERK signaling, which is a cascade of phosphorylation event that lead to also finally to transcription of K gene that are involved in cardiovascular homeostasis. Most of the drugs developed so far regard the cancer. As you can see that some of them are already in clinical trials and try to inhibit the signaling by inhibiting phosphorylation events. But nowadays there are also more specific drugs, particularly the dimerization inhibitor, which block the signaling to reach the level of nucleus. And this is associated with more efficient inhibition, but also less side effect, particularly in cancer therapy. Now, the reason why I'm talking about the cancer therapy is because cancer research is developed probably more rapidly and more efficiently than the cardiovascular research. So it's very interesting and very important to consider drug used in cancer like this MEK inhibitor to see if there is some potential application for cardiovascular patients. And in fact, in the research conducted by my fellow and published recently in Journal of Clinical Investigation, we found that one compound, one MEK inhibitor that is used in cancer was useful to reinforce the pericyte ability to establish contact with the nascent neovascularization in a model of myocardial infarction. And this led to consistent increase in angiogenesis and improved perfusion, but also more efficient contraction of the heart after infarction. I have also to say that in many other applications in drug repurposing, you cannot use a drug as in cancer, so for instance by daily administration, but you need to conduct a refined pharmacokinetic study to reduce the side effect, like in this case, and increase therapeutic efficacy. So we administered the drug only for 2 weeks immediately after myocardial infarction, as the neovascularization persists for a long time. We also conducted a histological study and to understand if the increased perfusion was due to improved angiogenesis and arteriogenesis. You can see in this part of the slide that arterial density was significantly increasing after the treatment with this MEK inhibitor. We also studied a molecular network associated with the administration of this compound, and we found also that the administration of MEK inhibitor modifies the transcriptional regulation of human pericyte, and so allow us to discover new candidate for targeted therapies that we can consider in the future. The second and last part of my presentation regards cardiac steatosis. This actually is not a very well-known pathology, which is actually associated with more known condition like hepatic steatosis. So in this case, lipid accumulate in liver, but also within the myocyte. And regarding the heart, they can produce a damage in terms of contractility, particularly lead to diastolic dysfunction. So we tested in a model of cardiac steatosis in diabetic mice the possibility to block or at least reduce the accumulation of lipid in the heart, but simultaneously also reduce senescence in the heart. In fact, this compound, which is used also in cancer, is also considered a senolytic agent. Senolytic agents are basically compounds, like in this slide, other example, which block the survival signaling in aging cell and drive the senescent cell towards apoptosis, so eliminate senescent cell. This is quite important because while eliminating senescent cell, you also can block the vicious cycle that leads this senescent cell to secrete inflammatory factor that damage other neighbor cell. And desatinib is also in general used in experimental model together with other compound in a cocktail of senolytic agent. In our study, actually, we used only dasatinib, a single drug, to see if it can eventually be effective in cardiac cetosis in a diabetic model. We use two protocols. In the short treatment protocol, we couldn't find any benefit on cardiac function. But on the other side, we were able to decrease the amount of lipid accumulation in the heart and the bone marrow. We then looked at longer term administration, and you can see here that the contractility was not improved, but interesting, we found that the prolonged therapy in diabetic animal improved diastolic function, which is more linked to the limitation of cardiac fibrosis. In fact, when we examined the disease heart, we found again a decrease in lipid accumulation, but a dramatic decrease in cardiac fibrosis, which is actually one of the main drivers of diastolic dysfunction. And simultaneously, we also observed a reduction in cardiomyocyte senescence. So just to summarize my presentation, I tried briefly to convince you that the drug repurposing can be a convenient method to accelerate the clinical translation of existing drug and therefore limit somehow the drawback of classical drug development. Different approach can synergize in extending and refining the best use of drug repurposing for treating specific classes of patients, and potential cardiovascular target includes aging cardiomyopathy, ischemic cardiomyopathy, and cardiac steatosis. Thank you very much for your attention.
Professor Madedou, very exciting and very challenging work. Congratulations. And I would like to ask you something for the future. What is your view about the new treatments regarding the angiogenesis and the CRISPR-Cas9, the genetic treatments? Are we near? Are we far from there?
I think that after a period of enthusiasm for gene therapy, which doubles the limitation, because as you know, particularly VEGF trial were disappointing, but also complicated by the use of viral vector, which somehow limit the possibility of repeated treatment. There is now a new trend towards trying to stimulate endogenous angiogenesis, again, by the common drug. I gave you an example. So a cancer drug can eventually stimulate endogenous pericyte to promote angiogenesis. The other possibility is use a protein instead of gene. Now, protein are exciting because don't present the limitation of viral vector dependent gene therapy. The limitation of protein therapy is the source, the delivery system. But for instance, I'm working in collaboration with a company in US that is developing a protein already applied in 1,000 stroke patient in China, but it was a protein extracted for urine. They developed a recombinant protein, a kallikrein, and I'm very affectionate to that because it was I was the first to discover the kallikrein angiogenesis. They are conducting now a trial in stroke patients in the US that seems to be quite promising. So to answer your question, I believe very much in the possibility to stimulate endogenous angiogenesis, somehow modifying the cell, endogenous cell, and the second is using protein therapy instead of gene therapy.
Okay, thank you very much. Thank you very much for your excellent presentation. Thank you.
Thank you.
would now proceed with session 13, Interactive Workshop 5. It's coordinated by Professor Dr. Andreas Pitaras, and we would like to call upon the chairs, Dr. Georgios Miltiadou and Dr. Stelios Hadjistilis. The commentators are Dr. Sostakis Aroditis, Dr. Dimitris Hadjis, and Dr. Karalambous Grassos.
Okay, hello everyone. Okay, we proceed to the next session, which is about hypertension. This session has commentators, but due to the fact that we are very late, we're not going to proceed to any discussion other than the presentations. And also, I kindly ask the speakers to keep in time because we are late on time, late the time. So we start this session with Professor Dr. Charalambous Grassos, and we're going to. The title of the presentation is the impact of environmental factors on arterial hypertension and associated cardiovascular disease. Professor Grassos, nice to have you with us. Thank you, and we are looking forward to your presentation.
Good evening, dear colleagues, dear presidents, dear students. Before to start, I would like to thank the organized committee, especially Professor, my best friend, John Patrikios, for your kind invitation to participate as a faculty and, of course, as a scientific person in this beautiful Congress. I'm going to talk about the impact of environmental factors on arterial hypertension and associated cardiovascular diseases. So let me start my presentation with this beautiful slide illustrating the contribution of environmental toxicant to our health in aging, and actually one of the most important diseases that cause cardiovascular disease is for sure arterial hypertension. According to the new guidelines of the European Society of Cardiology, emphasize that the role of air pollution is to increase elevated blood pressure and also hypertension as a part of multifactorial condition. And the more prominent pollution events in the 20th century with catastrophic effects on the human health were the following. First, in Belgium, in Meuse Valley, as you can see, there is 3-day episodes, kills more than 63 persons. In 1940, in Donora smoke, we have 20 dead. And of course, in 1952, the great killer smoke in London kills more than 4,000 dead. And as you can see in this photo, lot of buses are escorted by lantern 10 and 30 in the morning. These pictures come from Lahore, Pakistan, where a school closed due to air pollution. Also, I would like to point out that this picture was taken recently this November. In these slides, you can see that a normal person takes per day 20,000 and 25,000 breaths. You inhale 5 to 8 liters of air per minute, which is about 11,000 liters of air per day, adds up to more 300 million liters in a lifetime. So, what about air pollution relative to other leading risk factors for global mortality? The air pollution stands in the 3rd position. As you can see in these slides, environmental pollution affecting all over the world. Alone air pollution stands to the 2nd most important risk factor to develop cardiovascular disease worldwide. But external environmental factors, there is not only air pollution, but also the exosome, and of course, the noise pollution, the light pollution, the wastewater. There is also effect and direct and indirect to increase cardiovascular disease using the classical risk factors such as diabetes, pulmonary infection, hypertension, coronary syndrome, kidney disease, etc. Which is the typical pollutant interesting? The most important pollutants are PM 2.5 and of course the particulate matter PM 2.10. And what exactly is the PM 2.5 and where come from? They are outdoor and indoor sources of fine particles, primarily coming from trucks, cars, buses, and off-road vehicles. And the PM 2.5 is also produced by common indoor activities, some indoor sources of these fine particles, such as tobacco, smoke, cooking, and etc. And what is particulate matter 2.4? In order to have a relative comparative size, it will hypothetically make a comparison with a human hair, which is about 50 to 70 microns. The particulate matter 2.4 is 3 times smaller. The problem of pollution has been known since many centuries ago. As you can see, the King Edward I in 1271, as called Malus Scotorum, solemnly state that whosoever shall be found guilty of burning coal shall be suffer the loss of his head. Regarding the origin of air pollutants, they can be of either anthropogenic or natural origins. For more specific, some examples of anthropogenic sources are motor vehicles, power plants, household furnaces, and of course, the industry pollutants. Let's get back to the pathophysiology that the air pollutants increase the blood pressure. As you can see, the entrance points are naturally the lungs, via which they gain access to the bloodstream. As a result, they cause autonomic nervous system dysregulation. This leads to oxidative stress. Oxidative stress is known to cause endothelial dysfunction through the vessel construction and other pathological conditions. They ultimately lead to be increase on arterial blood pressure. In this slide, you can see the consequences of air pollution. We have the long-term consequences that increase the risk of ischemic disease, increase the cardiovascular mortality, and of course, increase blood pressure. And we have also the short-term consequences that increase the hospital admission, increase the cardiovascular mortality, and of course, increase the risk of myocardial infarction. In this beautiful meta-analysis, we see that the blood pressure increase in acute environmental pollution is increased by 1.4 millimeter mercury, the systolic blood pressure, and 0.9 millimeter mercury, the diastolic blood pressure, and in the chronic basis by 7.3 millimeters systolic blood pressure and 9.5 millimeters mercury in diastolic blood pressure, respectively. This study involved more than 35,500 non-hypertensive adults in Canada. The increase in PM 2.5 by 10 micrograms per square meter were responsible after 6 years for 8,600 new hypertension cases. This is equivalent of 30% the rise of incidence of hypertension. Acknowledging the gravity of importance of this issue of atmospheric pollution and arterial hypertension, we published with my colleagues this article in the Journal of the American Society of Hypertension. And not only in the adults population, we have the increase of blood pressure according to their pollution, but as you can see in this study, also we have increase in children and adolescents. The goal of these results was to study the long-term effect of environmental pollution in arterial hypertension in the big people in China. And as you can see, the findings of this study suggest that the long-term exposure to the ambient PM2.5 might be an important risk factor for hypertension. It is responsible for significant hypertension better in adults in China. In this slide, you can see a plethora of epidemiological studies that link the air pollution with cardiovascular disease. As you can see, all these studies coming from the area of Asia and the China. And we have almost some studies coming from Europe. As you can see, this study explored that the indicate that the long-term exposure to air pollution coming from Europe, the study called ESCAPE trial, that suggests that exposure to outdoor air pollution might be linked to hypertension. Another big question is, does air pollution destabilize atherosclerotic plaques? Of course, we have some data about that. As you can see, there is a strong relation between ambient air pollution and atherosclerosis, with the rupture of atherosclerotic plaques, because the atherosclerotic plaques facilitate by increase in heart rate, increase in blood pressure, and of course, we have the activation of the sympathetic nervous system. Moreover, it was observed that exposure to traffic, even for just 1 hour, can cause acute myocardial infarction. And not only acute myocardial infarction and heart failure, as you can see in pollution, there is a strong association between the air pollution and the hospitalized and mortality related to heart failure. PM2.5, it's very clear, drives to atherosclerosis and acute cardiovascular events. And if we want to ask to the question, how many people die from air pollution each year, you can see, according to this study, that more than 8.8 million dies from cardiovascular disease due to air pollution. But not only air pollution, and also noise pollution, it's linking with cardiovascular disease. This is the report of environmental noise in Europe in 2020. As you can see, 20% of the European population live in areas where environmental noise levels are harmful to the health, more than 55 decibel. 100.3 million people are affected of road traffic noise. 22 million are exposed to high levels of railway noise. 4 million are exposed to high level of aircraft noise. And finally, 1 million are exposed to high level of noise caused by industry. With the mechanism, the pathogenetic mechanism that noise increase the cardiovascular disease, as you can see, there is 2 roads, the direct pathway and the indirect pathway. All these roads lead to the activation of sympathetic nervous system, and of course, we have the chronic stress responses about that, such as blood pressure, cardiac output, and cardiovascular disease, such as arterial hypertension, ischemic heart disease. In this study, you can see that nighttime noise causes more persistent hypertension, especially in the people who live near to the airports. Of course, transportation noise are more important to provoke cardiovascular disease. There is a strong relation and association between road traffic noise and cardiovascular disease. And we go to another point, that climate changes through the increase and decrease of temperature, but also through other weather phenomena, such floods and droughts, have various health effects, and of course, cardiovascular problems. Heat waves, cold spells, and the heart provoke myocardial infarction. This is the meta-analysis for 23 studies. Another important issue is that there is a strong relation between temperature and the incidence of atrial fibrillation. Per each 1 degree of temperature, we have more cases of the new cases of atrial fibrillation. What about fluids? 35 countries, 11.1 million cardiovascular deaths, as you can see, the increased risk of cardiovascular mortality that persists for 50 years. What does this mean for clinicians? This is the important things that what kind of protective measures should be taken. First of all, if we have a PM 2.5 more than 3.5 microgram per square meter, we need to take some action. All these people, should be taking some information about the atmospheric air pollution and remain to your homes. Of course, in other values of PM 2.5, and of course, if the PM5 it's over 150, the most of the people must be stay into your home with close the windows. To be more specific, there are the new guidelines for cardiovascular prevention in clinical practice that emphasize the role to the air pollution and to and the association with cardiovascular disease. And of course, the new in 2024 European Society of Hypertension guidelines, the clinical practice guidelines, emphasize the role of air pollution and cardiovascular also disease. Taking into account my presentation, we understand that we have to take immediate action both on a population level, such as air quality guidelines, national and local ordinance and regulation, transition to cleaner, renewable energies, and of course, some action in the personal levels. We need to have portable air cleaners, 994 respiratory face masks. We know that they use this mask during the COVID epidemic, behavioral lifestyles, and of course the medications such as statins and fish oils. To sum up, environmental pollution, air pollution, noise pollution is a major yet still underestimated modified risk factor for hypertension, cardiovascular disease, and mortality. Current global regional efforts are insufficient to mitigate pollution, induce adverse health outcomes. More funding for research and better implementation strategy are necessary to support novel solutions. And finally, evidence-based guidelines specifically targeting pollution related to hypertension and cardiovascular risk are lacking. Thank you very much for your attention.
Professor Grasos, due to lack of time, have to proceed to the next lecture. Sorry. Well, I invite Professor Christos Savopoulos, Professor of Internal Medicine, Aristotle University of Thessaloniki, which the title of presentation is Can Patients with Cardiovascular Risk Factors and Comorbidities Benefit for Ambulatory Blood Pressure Measurements? Well, we all know that ambulatory blood pressure measurement helps to control better the blood pressure, but the question is whether this blood pressure measurement helps to improve the outcome of the patient. Well, Professor Savopoulos.
Good afternoon, dear Chairman, dear colleagues, ladies and gentlemen, dear students. First of all, I would like to apologize for not being able to present my talk in person, and then I would like to thank my friend, Professor Ioannis Patrikios, for his invitation to participate again to this very annual scientific meeting. And I would like to share with you a few minutes as introduction. And according to Neil Poulter,
who is expert and a big name in UK and worldwide in the field of hypertension, the raised blood pressure continues to be the biggest contributor to the global burden of disease and to global mortality, directly or indirectly, leading to this huge size, to this huge number of deaths, namely 10.4 million deaths each year. And as you can see in this slide, hypertension is a leading cause for cardiovascular morbidity. This is a long-term trial with a follow-up over than 35 years in patients aged between 35 to 64 years. And you can notice the high rates of coronary artery disease, the stroke, the peripheral artery disease, and the heart failure among hypertensives when compared to normotensives. And cardiovascular mortality risk doubles with an increase of each 20 millimeter of mercury for systolic and 10 millimeter of mercury for diastolic blood pressure, respectively. Also, we can see the high mortality risk about an increase of 8-fold in hypertensives with the higher levels of blood pressure. And it seems like a tsunami that affects and causes damage in organ targets such as brain, eyes, heart, kidney, and peripheral artery and peripheral vessels. And this slide could be the first home message. You can see that in the frame of primary prevention, both physicians, both doctors as patients have plenty of time to control all these certain cardiovascular risk factors such as diabetes, hypertension, smoking, dyslipidemia, obesity, and to avoid these effects like coronary artery disease, stroke, and others. And if we can manage to control these factors, another event will occur. And in the same of secondary prevention, we have lesser time to avoid a recurrent event, since another one will occur, mostly more severe and possible fatal. And except the in and out of office blood pressure measurements, according to the very recent guidelines of the European Society of Cardiology, we can offer an ABPM recording, use a validated blood pressure machine, which will record the blood pressure every 15 to 30 minutes during the day and every night and every hour during the night. However, in order to export safe and accurate results, it is necessary to have at least 70% of valid recordings. And please, could you upload this slide? It's my first question to the audience in order to make my presentation more interactive. And it's with regard to the definition of hypertension according to ABPM recordings. If SAP, systolic blood pressure, is equal or over 130 millimeter of mercury and diastolic equal or over 80 millimeter of mercury. B, if systolic blood pressure is equal or over 135 millimeter of mercury and diastolic equal or over 90 millimeter of mercury. C, nighttime or sleep with a mean systolic blood pressure level equal or over 120 millimeter of mercury and diastolic equal or over 70 millimeter of mercury. D, daytime or awake mean systolic blood pressure level equal or over than 135 millimeter of mercury and diastolic equal or over 85 millimeter of mercury. And E, the combination of A, C, and D. You can vote. You have some seconds to vote. Could we see the results? I can see the results. I can see the results, but the correct answer is the E, since in order to define measurements, it's necessary to have a 24-hour mean systolic blood pressure level equal or over 130 millimeter of mercury and diastolic equal or over 80 millimeter of mercury, and daytime or awake mean systolic blood pressure equal or over 135 and diastolic 85 millimeter of mercury, and nighttime or sleep mean systolic blood pressure equal or over 120 and diastolic equal or over 70 millimeter of mercury. And this is my second question with regard to the clinical indication for ABPM. Please upload also this slide.
Professor Savoulos, I think that you have to proceed because we have the opportunity to do this questionnaire.
Okay. Are we okay now? Could we see the results of this vote? The correct answer is E, since the main clinical indication for ABPM suggested by the available studies are white coat phenomenon, mask hypertension, nocturnal hypertension, and over 20% difference between office and out-of-office blood pressure measurements. Also, the typical phenomenon can be checked by ABPM, and it is defined as a drop of blood pressure between 10 to 20% in normotensive and untreated hypertensive patients. And the possible explanation is the circadian variation in BP during the night. And all the aforementioned indications and definitions are included in this slide according to the recent guidelines of European Society of Cardiology. And let's move on our trial in which 44 patients with over 20% difference between office and out-of-office blood pressure measurements participated in our study. We checked their medical history for cardiovascular risk factors as dyslipidemia, diabetes mellitus, and coronary artery disease. And our patients were under 24-hour ABPM, and they were classified according to the rate of the drop in their systolic blood pressure during 24-hour recordings into 4 categories: the extreme dippers with a drop of blood pressure, of mean blood pressure over than 20%, dippers where the drop was between 10 and 20%, non-dippers when the drop with a drop lesser than 10%, and reverse dippers or risers when there was not a drop or even an increase in blood pressure. And you can see the results. About 57% of our participants were men with mean age about 56 years. 41% of the patients had a history of hypertension, 37 dyslipidemia, 16 diabetes mellitus, and 18 coronary artery disease. 2/3 of them were just to be normotensive, but 1/3 of them had a history of hypertension and they were under medication. About 12% were just to be hypertensive, 7% with isolated diastolic hypertension, and 5% with isolated systolic hypertension. I would like to focus to this result that according to ABPM, we change the medication in about 1/3 of the patients. And this is my last question. And in order to save the time, the correct answer is actually E. Since according to our results, we are not able to demonstrate that patients with difference between office and out-of-office blood pressure measurements and medical history of hypertension, dyslipidemia, or diabetes mellitus could benefit most from ABPM because there was no difference in mean systolic and diastolic values of a 24-hour, daytime or nighttime, and so no difference in hypertension patterns. However, in patients with history of coronary artery disease, these patients could benefit from ABPM so that physicians could choose the appropriate treatment to achieve the best blood pressure targets. And I would like to explain in a few minutes our results, in particular the beneficial effect of ABPM to hypertensive with a medical history of coronary artery disease. I would like to apologize for this slide that is written in Greek. It's a publication in the official Journal of Hellenic Association of Hypertension, and it's with regard to the theory of chronotherapy and chronopharmacology. Chronotherapy of hypertension studies the administration of the correct amount of active substance through the appropriate pathway at an appropriate time for the main categories of antihypertensive drugs, such as beta blockers, diuretics, calcium channel blockers, ACE inhibitors, and ARBs. And we had the chance to investigate the chronotherapy in this, our previous post-mortem retrospective study in collaboration with the Department of Forensic in our university, with regard to sudden cardiac deaths due either to acute myocardial infarction or to chronic ischemic heart disease. And you can notice that except the expectant peak after the morning awake, there is another peak during the afternoon that could be explained by the phenomenon siesta. It is well known that Mediterranean people used to sleep after the lunch time, and then the afternoon awake mimics the morning one, and this could explain this peak. And according to, and also when I had the chance to do my sabbatical before 13 years in Imperial College, we ran this study, the Harmony study, 50 patients, 50 hypertensive patients from St. Mary's Hospital in London and other 50 patients from Acheba Hospital in Thessaloniki in Greece were recruited to participate to this study, and they received their antihypertensive medication once daily, either in the morning or in the evening, and after 3 months they underwent an ABPM. We cross over the patients, and after other 3 months they underwent another ABPM, and then we collected the data, and according to the analysis, you can see in this publication in the official Journal of European Society of Hypertension, among hypertensive patients with reasonably well-controlled blood pressure, the timing of antihypertensive drug administration, namely morning or evening, did not affect mean 24-hour of clinical blood pressure levels. And as you probably remember, in about 1/3 of our patients with a medical history of coronary artery disease, we changed their medication, and these patients their medication divided into morning and evening receiving, and this fact could explain the beneficial effect of ABPM to this category of patients. And at this point, I would like to close my lecture with a reference to our stroke unit, since hypertension is the main risk factor for stroke. And this stroke unit in our department offers its service to patients with acute ischemic stroke. And till now, about 120 thrombolysis were performed and other 12 thrombectomies. Thank you very much for your attention.
Thank you very much for this excellent presentation. We're not going to have any questions because we are late in time, we're going to proceed to the next presentation by Evgenia Kayakousi. She's an associate professor in internal medicine and hypertension at the 3rd Department of Internal Medicine, Papageorgiou Hospital at Aristotelia University of Thessaloniki. And the title of the presentation is going to be Women Are Not Just Small Men, Sex Differences in the Management of Arterial Hypertension.
Good afternoon. It is a pleasure to give this talk in this Congress, and I would like to thank Professor Patrikios for this kind invitation. My first question, my talk will start with the first question, that the prevalence of hypertension in women is higher than the prevalence of hypertension in men after the age of 65 years old. It is always lower than the prevalence of hypertension in men, always higher than the prevalence of hypertension in men. And the correct answer, I understand that we will give the correct answers. The correct answer is A. The prevalence is higher after the age of 65 years old. And I will begin my talk by saying that the total prevalence of hypertension is not different during the life of a woman and man. It is similar, with some disparities according to some regions, world regions. However, until the age of 60 to 64 years old, the prevalence is lower in women, while after the age of 64 years old, the prevalence is higher in women as compared to men. And what is different, it is the life trajectory of blood pressure and not the total prevalence of hypertension. So women catch up blood pressure levels in men during midlife, but if you will see in this graph, as you can see, there is a faster increase in blood pressure in women compared to men, and this starts at the age of almost 30 years old. The second question refers to the key factors affecting the future cardiovascular risk in women.
Sorry to interrupt you, Professor.
Reproductive life.
Sorry to interrupt you, Professor, but we cannot see your slides, so bear with us 1 minute, please.
Yes. Shall I start sharing again?
Just bear with me 1 second because I'm not sure what you should be doing. Should we start sharing? What should we do? Control, what should we do?
I will give it a try again.
Try again with sharing. I think you need to go on slide share because we're not actually watching slide share, we're watching individual slides. Which slide are you on now?
I went back to the beginning of the document.
No, continue from where you were. Try scrolling down just to see. Okay, now we can see something saying second question. Okay, we can see it now. Thank you.
Oh, good. Okay. Now the second question is, which are the key factors affecting the future cardiovascular risk in women of reproductive life? The history of infertility treatments, the history of gestational diabetes and hypertension, early or late age menarche, or the above. And of course, the correct answer is all of the above. There are some key stages of the woman's reproductive history that are associated with future cardiovascular risk. And these key stages start from the early life, and they may be the early or late age of menarche. There may be also polycystic ovary syndrome, some infertility treatments, or the use of oral contraceptive pills. Also, adverse pregnancy outcomes, mainly gestational hypertension, preeclampsia, or gestational diabetes, and of course, some events around menopause that may affect the future cardiovascular risk. The third question is, which of the following is correct? Women present more often with masked hypertension. Women have rarely left ventricular what we know regarding the hypertension phenotypes is that women present more often with white coat hypertension, while men present more often with masked hypertension. Also, some traditional conventional cardiovascular risk factors are more often in women than in men. And this is the central obesity, also the presence of metabolic syndrome, autoimmune diseases, and also the renal dysfunction. And about central obesity, there is a higher prevalence in women as compared also to promenopausal women and also as compared to men. And this is something stable and starts from the age of 45 years old and on. And also, there is the prevalence of renal dysfunction is greater in women when this comes to measuring microalbuminuria, while in men there is more deterioration of the GFR. There is a more rapid progression of renal function and a worse renal outcome in men rather in women. There are also some differences in the hypertension-mediated organ damage. Women have higher pulse wave velocity. They have also a shorter arterial tree. The reflected waves come back earlier from the periphery. This increases the central blood pressure, and also we have the presentation of isolated systolic hypertension. Also, left ventricular hypertrophy is more common in women than in men, and this applies also for the LA dilation. And also, it is more often atrial fibrillation. Also, we have many microvascular dysfunction, microvascular damage that affects also the renal circulation, but also the brain circulation. In premenopausal females, we have the beneficial effect of estrogens, and this causes endothelial vasodilation, inhibition of the activity of sympathetic nervous system and renin-angiotensin system, decrease in endothelin production, and also decreased oxidative stress and inflammation. After the menopause, the cardiovascular risk rises very sharply, and this is mainly due to the loss of cardioprotective effects of estrogens, which lead to endothelial dysfunction, upregulation of sympathetic nervous system and renin-angiotensin system, and also increased salt sensitivity. Which of the following question is correct? Women experience increased cardiovascular disease risk for higher levels of blood pressure as compared to men. Women are less adherent to antihypertensive treatment as compared to men. And women, when it comes to lifestyle changes for the management of hypertension, women respond better in aerobic exercise as compared to men. The correct answer is B. Women are, it is known that they are less adherent to antihypertensive treatment as compared to men. We know that they experience increased cardiovascular risk, as this is presented as cardiovascular disease, myocardial infarction, heart failure, or stroke, for lower levels of systolic blood pressure as compared to men. And also we know that the hypertension-related danger risk for acute MI, it is higher in women than in males. And the same applies for the deaths attributed to strokes, attributed to brain disease. Of course, these are observational data, and we need more prospective clinical data in order to be able to clarify the different response between males and females according to the major cardiovascular events. But also, the associated with hypertension risk seems like that it is higher in women as compared to men when it comes for the heart failure with preserved ejection fraction, atrial fibrillation, dementia, and cognitive decline. We don't have enough data in order to be able to express a definite opinion about the effect of antihypertensive treatment, and then if there is any difference in the effect of antihypertensive treatment. This is mainly because women are underrepresented in the main randomized clinical trials. We have only a few data, and these are from secondary analysis. Nordil study, it is a very old study, showed no difference between the response of male and females, while the HOT study, again a very old study, showed that women experience lower levels of MIs in the lowest diastolic blood pressure target group. When they have, that means when they have diastolic blood pressure lower than 80 millimeters of mercury. This is an Australian study, a big number of participants. It showed that male population responded better in the ACE inhibitors treatment, with a reduction of 17% in the major cardiovascular events as compared to women. But then a meta-analysis of the LIFE study showed that the women responded better with less left ventricular hypertrophy when they were on treatment with losartan. Finally, there is this very known meta-analysis, the TTC trials, 31 trials, almost 200 participants, 200,000 participants. They compared the effect of antihypertensive treatment and the reductions in blood pressure and the incidence of cardiovascular events, and they showed that there is no significant difference between men and women according to the whole trials, all the trials that they were investigated. Now, we don't have enough data in order to set different blood pressure targets when we treat hypertension in women and in men. What we know, there are only scarce data that refer mainly to the SPRINT study that showed that women did not exhibit a significant outcome difference whether they were in the standard group or the intensive treatment group, whether they were younger than 60 years old or older than 60 years old. Of course, this result may be due to the fact that women had lower cardiovascular risk in general, so they experienced lower rates of events. But
Evgenia, 2 minutes left. We have more 2 minutes, okay?
Okay. What we do know is that the hypertension management may have some problems in women. We know that women respond better to restriction in sodium, while men respond better to the aerobic exercise. But we also know that women experience more adverse effects in the most antihypertensive categories drugs. They have 50% greater risk of suffering from adverse events, and this applies for ACE inhibitors or ARBs. They are contraindicated in pregnancy, and we have twice risk of presenting with cough after treatment with ACE inhibitors. Also, dizziness, flushing, headache, tibial edema are more common in women when they are treated with CCBs, and also hyponatremia and hypokalemia when they were treated with thiazides. We know that after the age of 60, they are becoming less adherent to their hypertension control, and they receive lower numbers of antihypertensive drugs as they compared to men. And also men, as compared to women, they are less likely to stop their treatment. Women, that means that women stop their antihypertensive treatment more often than men. And above the age of 65 years old, it is definite that they are less adherent to antihypertensive treatment. What it is interesting to present is that regarding the control of cardiovascular risk factors after an MI, it has been shown that women, they do not understand the risk that they are into and what they need to do in order to reduce this risk. It has been shown that the care provider, that means the doctor, didn't explain to them what exactly is the risk. And it is also unfortunate that they were not told what to do in order to modify their cardiovascular risk for secondary prevention of ischemic heart disease. There are some possible reasons for less adherence. Women are less aware of their CV risk factors. This is the same sometimes, and it applies also for the doctors. Usually they are the main caregiver of the family, and this sometimes has a negative impact on their health. It may be financial reasons that they are less adherent to men, and also they have, as we showed, higher rates of adverse events regarding the hypertensive treatment, and this fact renders them more non-adherent in their treatment. So in summary, hypertension prevalence in women is higher than men after the age of 65 years old, although the total prevalence is not different. Women experience higher CV risk for lower systolic blood pressure levels. Throughout women's life, there may be sex-specific events that are related to greater long-term CV risk. We need to pay special attention to hypertensive disorders of pregnancy, infertility treatments, and other syndromes, and also the use of oral contraceptive pills. Women exhibit also differences in the hypertension-mediated organ damage, and hypertension phenotypes are different as compared to men. They experience worse blood pressure control with less drugs, and they are more likely to be non-adherent in treatment. And also, they are more likely to experience adverse effects from antihypertensive drugs. There is insufficient evidence to recommend different treatment strategies regarding blood pressure targets, and also we need future clinical research, more studies that they will include higher numbers of women participating in these studies. Thank you very much for your attention.
Okay. Professor, thank you for this excellent presentation. We have to move on to the next presentation.
Well, we proceed to the Dr. Manolis Kallistratos, President of the Work Group of Arterial Hypertension, Hellenic Society of Cardiology. The title of presentation, so many guidelines, so little time. Critical review of guidelines for the management of arterial hypertension, European Society of Hypertension versus European Society of Cardiology. Dr. Kallistratos, please.
Distinguished chairpersons, distinguished colleagues, I'll try to be fast in order to catch time. These are my disclosures. We all know that arterial hypertension practically represents the leading cause of death worldwide. Imagine that every year, almost 11 million patients are dying from causes directly or are directly related to arterial hypertension. And the reason is simple. You can see how a slight increase of blood pressure levels may significantly increase the cardiovascular risk of mortality. On the other hand, if we decrease and control blood pressure levels, and we have the means to control blood pressure levels, with a triple fixed combination at maximum doses, we may control almost 90% of our hypertensive patients. You can see how significantly we may decrease cardiovascular morbidity and mortality. Although now we know the importance of blood pressure control and we have the means to control blood pressure levels, unfortunately, globally, but also in Greece, these are the latest studies performed in Greece, the triple MDMNO, the percentage of patients with controlled blood pressure are at least suboptimal. And that's why we need current guidelines. That's why we need recommendations in order to improve our practice and to further decrease and control in more patients blood pressure levels. And for the last 20 years, as you can see, we have the joint guidelines of the European Society of Cardiology and the European Society of Hypertension that gives us several recommendations regarding treatment and control of blood pressure levels. However, in the last year, in 2023 and 2024, we had separate guidelines from the European Society of Hypertension and from the European Society of Cardiology. Now, the paradox here is that despite the fact that we have new drugs, new combinations, unfortunately, the percentage of patients with controlled blood pressure remains at least suboptimal. Now we know that there is a linear correlation between blood pressure levels and cardiovascular events. The higher the blood pressure level, the higher the risk for the development of a subsequent cardiovascular event. And this is valid also for patients with blood pressure levels below 140 to 90. And that's why we have this category of optimal normal and high normal blood pressure levels. And in the last 20 years, as you can see, the joint ESC and ESH guidelines had this classification of blood pressure levels: optimal, normal, high normal, grade 1, 2, 3 hypertension, and of course, isolated systolic hypertension. What we have now, this new guideline from the European Society of Hypertension, and we don't have grades. We have non-elevated blood pressure if systolic blood pressure is below 122 millimeters of mercury and diastolic below 70 millimeters of mercury. We have elevated blood pressure if blood pressure levels are 120 to 139 and 70 to 89 millimeters of mercury for systolic and diastolic respectively. And we have hypertension, not arterial hypertension, in order not to confuse with pulmonary arterial hypertension if blood pressure levels are equal or above 140 to 90. And here comes my first question. As you can see, this is a real patient with blood pressure levels of 174 of systolic diastolic. And according to these guidelines, I have to argue with this patient. We have to discuss after 3 months of lifestyle changes to start treatment since he has elevated blood pressure levels if this patient has a high added risk for the development of cardiovascular event. And here is an algorithm. As you can see in patients with elevated blood pressure levels, after 3 months of lifestyle, we have a strong recommendation, not strong evidence, to start treatment if blood pressure levels remains above 130 to 80. And this is a score adjusted for the Hellenic population. And as you can see, if we take our elder subjects, elder patients, the majority of them below 85 years old are at least at very high added risk. So this is a question. Of course, ESC guidelines have the ALARA principle, which means as low as reasonable achievable, which is the same practically with the ESH guidelines. If tolerated, both means individualization. And we should not start antihypertensive treatment at this threshold. If the patient has orthostatic hypertension, he's above 85 years old, he has significant moderate to severe frailty, and of course, he has a low lifespan. All this recommendation, came from this meta-analysis with the astonishing result of, for every 5 millimeters of mercury decrease of blood pressure level, you can see we have a 10 decrease in cardiovascular risk, irrespectively of age, previous cardiovascular disease, and baseline blood pressure levels. However, this was a meta-analysis with significant limitation. For instance, they include many important trials. They didn't include trials like HOPE-3 and ACCORD trials. They include patients who were already on antihypertensive agents. The percentage of patients with systolic blood pressure below 120 was only 2%. They mixed placebo-controlled with comparison trials, and they had also other significant limitations. And for at least we can say that this meta-analysis could be at best as hypothesis generating. Another important thing is that according to the ESC guidelines, out-of-office blood pressure levels are more important from office blood pressure levels. And of course, in the ESH guidelines, they affirm that out-of-office are important in order to diagnose different phenotypes of hypertensive patients, such as white coat hypertension and mask hypertension. And if we use the ESC guidelines, we practically may miss subjects with white coat hypertension and mask hypertension, which are subjects with high added risk. And in order to use the out-of-office blood pressure measurements, as you can see, we have a correlation here for non-elevated and elevated blood pressure levels for home and 24 hours. However, this study was based, the DOCA and DACA study, there were two studies. They were accurate only for office blood pressure above 140 to 90 millimeters of mercury, and these results were accurate practically. However, these results were not accurately in these studies that practically mentioned in these guidelines. Another thing is who to screen for secondary hypertension, and according to the ESC guidelines with a level of evidence 2AB, we should screen all adults, and this is at least very costly. And the reason for this recommendation, it's because the prevalence of secondary hypertension is between 10 to 35%, which is extremely overestimated. Secondary hypertension is about 5 to 10%. And of course, the 50% of patients with resistant hypertension, the true incidence is extremely lower regarding the true resistant hypertension. Regarding now the therapy, they recommend to start with low-dose double combination. We will discuss it later and then pass to low-dose triple combination, which is a good concept, and of course then increase the separated drugs according to blood pressure levels. But as you can see, we have only 4 major antihypertensive drug classes. They excluded beta blockers. I think that it was wrong, since vasodilating beta blockers are very good drugs that decrease significantly blood pressure levels in the events. And here is a low dose, as you can see. They talk about azilsartan 40 milligrams, telmisartan 40 milligrams, losartan 25 milligrams, perindopril 2.5 milligrams. But on the other hand, the low dose of amlodipine is 5 milligrams, which is not a low dose. Of nifedipine is 30 milligrams, which is not a low dose, and the same is valid for the diuretics. So as you can see, this may confuse physicians, because if they use this low dose in slightly elevated blood pressure levels, they will induce hypotension. Of course, the target is the same, 120 to 129 for ESC, below 130, but not below 120 for the ESH. And regarding the management of resistant hypertension, we don't have significant differences. Fourth drug is the spironolactone, and then renal denervation is 2B in the ESC and 2A in the ESH. Thank you.
Thank you very much for your thorough presentation. I would like also to thank all for your participation. Thank you very much.
We'll now proceed with interactive shop number 6. Please, chairs, Dr. Petros Agathangelou and Dr. Dimitris Chatsis, come to the stage.
Okay, we move on very quickly because Professor Andrigopoulos will need to catch a flight. We had to make a little bit of a change in the sequence of the speakers. So George Andrigopoulos will start on. George.
Thank you very much, Petros. Thanks for the kind invitation. I'm sorry for having to discuss an issue that is not really as common as hypertension is. I really followed with interest the previous table, but I think it's going to be more interesting during the years to come, because we have more and more patients that undergo implantation of a device. And what we noticed about 30 years ago is that patients that have to be implanted with a pacemaker, at least a significant proportion of these patients develop heart failure, which means that the heart does not work with the pacing in pacing mode as well as the intrinsic rhythm. And in terms of pathophysiology, it was very interesting that we found out that the problem with pacing is that we reduce the ejection period, the period where a heart spends energy to contractile function. And that is because the isovolumic relaxation times is significantly increased, as you see here. So what we need to do is to correct the desynchrony that is caused by left branch block, because when we pace the right ventricle, we cause a pacing-induced left ventricular bundle branch block. And this is the first implantation. It's almost 24 years old. That was the first implantation in Evangelismos Hospital of a CRT system, of a biventricular pacemaker. In order to reduce or to give a definite therapy to desynchrony, we try to implant an additional lead through the coronary sinus. What you see there is the coronary sinus that goes on top of some branches, especially the lateral and posterolateral branches of the coronary sinus, go on top of the left ventricle. So instead of pacing the right ventricle, now we pace both ventricles. And we can synchronize them, and doing that, we manage to restore the electrocardiogram and also to restore the function of the ventricle. This goes back 22 years ago. It was one of our first cases. And this is the same heart. The left, you see what the synchrony is. The heart is not moving like that. It moves inappropriately rotating, and that has a significant consequence. It really diminishes the stroke volume. The next day, we had that echocardiogram, and you see that the shape of the heart is partially restored because of biventricular pacing. It can be also further improved if you go through the echo. And that was the first time, 24, 25 years ago, where we started to be confident that we can restore the synchrony and restore left ventricular ejection fraction, because some of these patients go from 25 to a near normal ejection fraction after successful implantation of a biventricular system. Another way to improve heart function through pacing is to use alternate pacing to diminish the possibility of atrial fibrillation or pacemaker-reduced desynchrony, which can be achieved. This is how we tried to do it back in 2005, using alternate site pacing. This patient, one of the first patients we did in Evangelismos Hospital, has a lead that paces the Bachmann bundle and a second ventricular lead that is pacing through the left branch. Now, for many years, we forgot alternate site pacing, but during the last years, we have focused again on these pacing modalities, trying to improve biventricular pacing, because the problem with biventricular pacing, which I showed you earlier, is that it is not always feasible. Even if you are highly experienced, there is a high chance that you are not going to be able to achieve implantation in the appropriate branch of the coronary sinus. For instance, in this case, the vein system was blocked. You can see the veins that are trying to bypass the blockage of superior vena cava. And in some other cases, this coronary sinus that is stopped, and it is stopped because the surgeons stopped coronary sinus because of the perioperative bleeding, possibly. It was very common some decades ago during cardiac surgery procedures. So in many cases, and this is a case where we had dissection of coronary sinus because we couldn't find an appropriate branch for the implantation, because it was very tortuous, as you can see. So there are many cases where you cannot achieve appropriate restoration of normal heart function in patients demanding pacing. That is why we went back to the original years where we searched for alternate site pacing. And what we do now is that when we fail or when we're not able to do appropriate biventricular pacing through coronary sinus, we try to pace left band branch. It's very common these days, but we have to keep in mind that data are still spare. Still, we are not sure if this will work after 10 years. Originally, I abandoned his pacing, a left band branch pacing, back almost 20 years ago, because we had cases where because pacing failed after a couple of years. So we have to be very careful when we jump to a new technology that has, although it is not an entirely new technology, because bundle branch area pacing cannot for the time being give us long-term results. But still, it's a valuable technique when we are not able to, especially when we are not able to offer to our patient biventricular pacing. But the most important part of this presentation is to make you realize that pacing is unavoidable. Of course, pacing is a life-saving treatment, but still you have to keep in mind that 10 to 30% of patients that undergo conventional pacing from the right ventricle suffer from a disease caused from pacing itself. the so-called pacing-induced desynchrony. And the only treatment for that is appropriate restoration of desynchrony through pacing of the left ventricle. Biventricular pacing through coronary situs is still the gold standard, but now we have also other modalities like the ones I showed to you that can help us overcome these problems. The other half of my presentation relates to atrial fibrillation. Why? Because atrial fibrillation is the single most important cause of health costs in the so-called Western world. It's the more frequent cause of admission to the hospital, and it's very important for our patients and for health payers. During the last years, we have been using electroporation in the form of pulse field ablation, which is a technique that overcomes some of the serious problems we had with other energies we used in the past. The most important and the most challenging feature of pulse field ablation is the fact that it causes apoptosis of myocardial cells. We don't kill any cells now. We don't create local fibrosis. We don't disturb the local structure of the tissues. And after 3 months, if the patients undergo MRI with LG, we see that there is no change in the tissues. So the most important advantage of this technique of pulse field ablation is the increased safety that it offers. And that is why a significant proportion of new tools that are developed in electrophysiology use this new kind of energy. This is an analysis. Of course, it's a registry. It's not a randomized trial, because so far there is almost 170,000 ablations performed, mostly in Europe, with this technique, because after, only 1 year before this technique was approved by FDA in the US, so the majority of cases have been performed in Europe. And the most important problems we had with atrial fibrillation ablation were the risk for esophageal fistula, the possibility of pulmonary vein stenosis after the ablation, because what we do with ablation mostly is that we isolate pulmonary veins, and in some rare cases, but still very annoying cases of phrenic paralysis. So with PFA, we have 0 of this complication. Most importantly, the patient the next day after the procedure does not feel anything, does not complain about pains, does not present affection problems with pericarditis. So it looks like the perfect solution for atrial fibrillation ablation, but it is not perfect. There is no such a thing as perfect in modern medicine, especially in invasive cardiology. So we found out that a significant proportion of patients, especially those that receive a high number of lesions, more than 70, may develop hemolysis. Hemolysis is not a clinical problem for the majority of patients, but it is a clinical problem for patients with chronic renal disease. So we have to be very careful, because there is no such a thing as totally safe procedure. And also, we have to be careful when we apply lesions with PFA close to coronary arteries because of the spasm, but this is not life-threatening and preventable complication, because we give nitro before applying the lesions. So it's still, if you take into consideration everything, it is still one of the most challenging techniques that have been used in cardiology during the last years, because it works. We have seen many new technologies, and most of them, they do not work. And that is why the industry has invested substantially in pulse field ablation. You see only some of the new tools that we have, and these are possibly the more exciting technologies, because now we develop catheters in the form of a sphere. Do you know why they develop catheters in the form of the sphere now? And these are possibly the more interesting catheters we have, because they don't trust doctors. Because every now and then, if you have a catheter, even if you are experienced, even if you are skillful, sometime you are going to perform a trauma in the heart. But with these catheters, there is no trauma, even if a young and experienced electrophysiologist works with them. And increased safety is the most valuable characteristic of new techniques. Of course, we still don't have enough data to support the theory of increased safety, but it's a really strange thing that when we use this technology, we can do things that we couldn't do before, like isolate isthmus in patients with a really peculiar anatomy. PFA is very capable to achieve blockage of conduction in areas where peculiar anatomy is present. The problem in electrophysiology has always been to stop perimitral arrhythmias because because of anatomic regions we couldn't succeed in the majority of our patients long-term good results. It looks like we can do that with PFA. We can isolate areas in myocardium within seconds when we needed hours to achieve long-term results. But still, and that is how I finish my presentation, the most important point of these new technologies is that patients and physicians tend to develop a different attitude towards these potentially life-threatening interventions. Because if you finish the procedure and you have no apparent complication, you can go home the next day and have a peace of mind, because the patient that goes out of the lab well is practically impossible to develop complications the following days. They don't complain about symptoms. You can go for fishing, Mr. Chairman, the next day and nobody will call you. For 24 years, I could never go for fishing on Saturday because you had at least 5 phone calls for symptoms that develop after AF ablation. And if a patient feels pain, then you have to have an echocardiography, an ECG, you have to send examinations, you have to deliver cost to the system. And so you lose fishing, health payers lose money. Now we'll have a new modality that helps us fight atrial fibrillation, minimizing risks. And saying that, I have to say that this is mostly a new technique that very important for the patients, because now the patients are willing to undergo a second ablation if necessary without having to worry what they're going to feel after the procedure. Thank you very much for your attention.
Thank you. Thank you, George. It seems like PFA will be the procedure for the near future, and that's going to be dominating. We wish you a safe return, and we thank you.
And now, without further delay, I would like to invite Dr. Briasoulis, Associate Professor of Cardiology at the National Kapodistriad University of Athens. Dr. Briasoulis. Dr. Briasoulis, you may start.
I'd like to thank the organizing committee for inviting me and express my apologies for not being able to attend and present in person. Still trying to share my slides here. Okay. These are my disclosures. I think it's taking a little bit of time to switch slides. Okay, so can you see my slides?
No, we can't.
Okay. Try once more.
We'll move to the next one.
No.
Okay.
So, Dr. Briasoulis, give us some time. We need to invite the next speaker. Is the problem solved? Okay. Okay, so you may start. Yeah, thank
Can you see them now? Okay.
Now we're okay.
Apologies
Please.
for the delay. So cardiac amyloidosis is an infiltrative disease with a very specific pattern on the echocardiogram characterized by hypertrophy, mildly reduced or preserved ejection fraction along with restrictive pattern and impaired longitudinal movement of the basal segments. And histologically, it's characterized by diffuse deposition of amyloid, particularly in the heart, but also in other organs. We do have two main types that affect the heart, light chain and transthyretin amyloidosis, and later has two types, wild type, which is more frequent, and the hereditary type, which is caused by specific mutations. Because of increasing awareness, we are seeing higher incidence and prevalence of cardiac amyloidosis cases in the last few years. And what we've noticed is that there are two main mechanisms involved in the damage that amyloid does to the heart, and this includes the mass effects, which causes disruption of tissue architecture, and also direct cytotoxicity by misfolded precursor proteins, but also light chains in the case of AL. So we have better treatments, and these patients, if they survive the first phase of treatment, especially in earlier stages of the disease, they go into a phase of stability, and during this phase, we'll experience cardiac complications, and that's when ourselves, cardiologists, will be involved. And from the arrhythmia perspective, although cardiac amyloidosis is not an arrhythmic cardiomyopathy according to the standards of cardiomyopathies, however, it's associated with high burden of arrhythmia, and specifically atrial fibrillation, which is found in over 50% of these patients, but also bradyarrhythmias and ventricular arrhythmias. So what are the causes? First of all, amyloid deposition, as we mentioned, cytotoxicity, and pre-existing myocardial scar. And we see these arrhythmias now in earlier stages of the disease because these patients live longer. I want to remind you here that in later stages of the disease, the main cause of death is electromechanical dissociation, but with better tools, we find these patients earlier, and we don't see that often. But how these arrhythmias present? Commonly, these patients experience syncope. But syncope in the case of cardiac amyloidosis is multifactorial. It can be because of autonomic dysfunction, diuretics, orthostasis, chronotropic insufficiency, or AV blocks and ventricular arrhythmias. So it depends on how we look at it. If we use long-term monitors like loop recorders, we can find that almost half of these patients have atrial fibrillation. One-fifth of these patients have atrial ventricular blocks, and also we find very frequent episodes of non-sustained VTs. And we do find atrial fibrillation in older wild-type transthyretin patients, whereas younger AL patients tend to develop atrial fibrillation during the course of the disease. However, atrial fibrillation doesn't determine prognosis. What it does do to these patients, though, it increases the cardioembolic risk dramatically, so which means that many of these patients have left atrial appendage thrombi, where we need to be extremely careful to exclude thrombi with transesophageal echocardiogram when we are planning either cardioversion and ablation. And having talked about cardioversion or ablation, there is a higher risk of recurrence of atrial fibrillation after we either try to cardiovert them electrically or perform an ablation. We have to keep that in mind. Now, atrial fibrillation is also a precursor or a risk factor for atrioventricular block, and we see that 10 to 20% of these patients will need a pacemaker. In fact, among patients with pacemaker and hypertrophy, 1 in 5 are found to have cardiac amyloidosis. So, and these patients do not suffer by sinus node dysfunction, but rather they have they have a disease of the AV node. And electrophysiologic studies have showed us that the HV interval is always prolonged, or it's prolonged in most of these patients with cardiac amyloidosis. Now, the patients who do develop high-grade AV block have worse prognosis, and these are patients mainly with wild-type disease. But we have to keep in mind that this is not an innocent bystander that just needs a pacemaker implantation. The patients who develop AV block in the setting of cardiac amyloidosis are the ones who will end up developing a ventricular arrhythmia with RND phenomenon. So it's AV block heralds higher risk of cardiac arrest in the setting of these dysfunctions. So overall, I would say that these patients have 4 times the risk for a pacemaker compared with patients with HFpEF. And many of these patients will have risk factors for an AV block, like first-degree AV block and wider QRS. And we need to be very careful during our monitoring, so which means that we have to look for these signs rather than wait for the patient to develop AV block and potentially a lethal effect. For example, patients with higher interventricular thickness and wider QRS are the ones that need frequent monitoring every 3 or 6 months, or even loop recorders if we are suspecting based on symptoms or other findings that may be at higher risk of developing an AV block. So our goal is to bridge them until treatment becomes effective, and we have to isolate those that are high risk for AV block. Now, if we decide to implant a pacemaker, which type of pacemaker should we implant? We have very limited data on the use of CRTs here. We expect that most of these patients will be pacer dependent. However, we have to keep in mind that the basal segments of the left ventricle are essentially infiltrated and poorly working, so the response to CRT will be less. We have some limited data, though, that CRTs are better than single chamber devices, and it's something that we're actively exploring. Now, moving on to ventricular arrhythmias, this is a topic that's still debatable. We know that patients with amyloidosis, especially AL amyloidosis, 1 in 5 of these patients will develop non-sustained VTs, and we don't see a specific prognostic implication of these arrhythmias. However, they develop these patients in these arrhythmias earlier in the disease, and while they are in the process of receiving treatment, perhaps before achieving response. And our duty is to treat these arrhythmias before these patients develop VT. This is a case of one of our patients that during a Holter monitor unfortunately developed a ventricular arrhythmia and died. So it's not only secondary prevention and indication for placing an ICD in these patients, but there is a weak indication, I would say, for patients with non-sustained VTs, those who are not in end-stage disease and have unexplained syncope, and potentially are candidates also for other therapies, including heart transplantation. Now, I wanted to mention here that so far data do not show benefit from ICDs. However, there are patients in our practice that have carried these devices, and what we've seen is that they had episodes of ATPs and they didn't have any ICD shocks, but many of these patients use antiarrhythmics, for example, amiodarone, and perhaps that's why we're seeing lower utilization of defibrillators afterwards. So it's a matter of debate, and we're looking forward to more data on the use of ICDs for these patients. So in conclusion, I would say that early treatment improves prognosis and prolongs life, so it's our duty to find these patients early, to identify them earlier, but as we identify them earlier and gather larger cohorts, we noticed that ATTR is associated with AV block, AL is associated with non-sustained VTs, cardiac arrest is rare, it's often precipitated by bradycardia and AV blocks, and although ICDs may not be very helpful. However, there are certain patients that may benefit from ICD, and also there are certain patients who are pacer dependent and may need an upgrade to a CRT. The main message I would say that we have to screen all patients frequently with Holter monitors or loop recorders if they have syncopes, unexplained syncopes, to find signs that will guide us to early implantation of an ICD. And I would like to conclude by saying that amyloidosis is not arrhythmogenic, but it's indirectly associated with high burden of all sorts of arrhythmias. And as we see more patients, we will have to take these aspects into consideration and perhaps change our practices. Thank you.
Thank you so much, Professor Briasoulis, for your very insightful lecture. So, and let me proceed with Professor Nikolaos Fragakis. Nikolaos Fragakis is Professor of Cardiology in the Aristotle University of Thessaloniki, and also he is the Director of the Second Department of Cardiology at the same hospital. Thank you.
Thank you, dear President, dear colleagues, dear students. I would like to express my gratitude to the organizing committee and especially to Professor Yannis Patrikios for this kind invitation. And I will go just in one case because of lack of time. This is the case, this is the patient, this 50-year-old female. She had a history of high burden of paroxysmal atrial fibrillation and hypertension. She underwent an RF ablation a few years ago, but which basically failed because even after the ablation, she kept having a high burden of paroxysmal atrial fibrillation, despite the use of 1C antiarrhythmic therapy, flecainide. At the same time, she had a history of major bleeding, numerous episodes of menorrhagia while on rivaroxaban, and she had many transfusions because of very low hematocrit during the last 3 years. And on the top of that, recently she had a non-STEMI, and she underwent a PCI in RCA. And please observe the first question and scan to vote. Which would you consider as the most appropriate antithrombotic therapy post-AC, post-acute coronary syndrome and PCI for this particular patient? Should she go for NOAC or for DAPT, aspirin plus clopidogrel? Third option is NOAC plus aspirin or clopidogrel. Third, NOAC plus DAPT. Fourth option, Coumadin. And sixth option is Coumadin plus DAPT. Please scan and vote. I don't know if we are ready for this. Well, probably we've forgotten that this patient had an acute coronary syndrome and PCI recently. So the right question actually is the third. Can I go to the next slide, please? Okay, this is the right answer. And so proceeding, we are in front of a patient that we have to face a usual problem. The patient had a quite high risk for a stroke, at the same time, high risk for bleeding. So how would you approach, according to your opinion, this patient at this stage? Should we decided that we have to give NOAC plus one of the antiplatelet, and clopidogrel is what we decided. So on the top of this, would you go for 1C antiarrhythmic agent? Should you go for amiodarone, beta blocker, any antiarrhythmic plus left atrial appendage occlusion plus clopidogrel, or would you go for left atrial appendage occlusion, clopidogrel plus PV isolation? Please scan and vote. Right. Well, I would say that is a little bit more conservative option compared to what we followed. Can we go the next? Yeah. Well, to be honest, it's not the right or wrong answer, but we followed the fifth one. And the reason is I would like to justify why we decided to go for this one. This is a practical guide for people that they do not implant left atrial occlusion devices, but help them to decide which is the most appropriate patient to refer for this potential procedure. Among the authors, I would like to point Apostolo Gikas, which is a member of our team. And in our case, as you can see, there is a recurrent irremediable major bleeding, and at the same time, we have a coronary intervention. So this patient could be potentially a candidate for left atrial appendage occlusion. Yeah, I have to admit that despite the progression that has been happened in this procedure, and at the same time some quite convincing trials for European guidelines, left atrial appendage occlusion still remains to be indication for patients with AF at the same time high bleeding risk, contraindication for anticoagulation, though in the other part of Atlantic, you can see that for the same group of patients, the indication is 2A. Needless to say that PV isolation, I mean that atrial fibrillation ablation is upgraded to 1A indication. So we decided, as I said, to go for this combination procedure, to go for a left atrial appendage occlusion at the same time atrial fibrillation ablation. So we did the pre-procedural planning. We measured the size of the appendage, and as Dr. Andrikopoulos explained to you very well, this PFA energy that we recently apply and is very popular as energy for AF ablation, we decided to apply PFA. This is the two configurations that we usually use, the basket and the flower. And you can see here a pointer. I hope that is this. Yeah? Okay, okay. You can see here that there are potentials in the PVs, and after the application of the energy, they disappear, and we check that there is an exit block, so we are sure that we isolated the PV. And after we proceeded to left atrial appendage occlusion with Watchman device. And after that, there was a question, how would you follow in terms of therapy? Should we discontinue NOAC? Is a single antiplatelet enough? Was left atrial appendage occlusion successful? And in 3 months' time, we proceeded to a CT scan, which is showed that the appendage was completely sealed. So we were allowed to carry on just with one antiplatelet. So why PFA over thermal ablation? Okay, Dr. Andrikopoulos explained why. Just I will stop in only 2 things that, they have some connection with this combination of procedure. One is that when we combine these 2 procedures, we have to make some compromise so that transeptal puncture should be a little bit more posterior and inferior compared to what we use for ablation. Because PFA is an energy that does not require very strong pressure on the tissue, is what they say at the moment. This helps because we don't need to attach very well the tissue. So even in a procedure that is not exactly at the level that we want, we can still isolate the PV. The second one is that using PFA, we create less edema, so we lower the risk of undersizing the left atrial appendage, device embolization, and peri-device leak. And of course, the combination increases the efficiency because it reduces the need for multiple interventions, safety because lowers the risk of repeated anesthesia, femoral vascular complication, transseptal puncture, improves outcomes because a holistic approach, and is a for patient convenience. I want to say that this procedure took 90 minutes overall, and the radiation time was 20 minutes. The rarity of our case, I think that is reflected in international publication, as only very scarce case reports appear in literature, like the one that I just presented. And with this slide, I would like to thank you and to underline that all these things cannot be done without a teamwork. And among the members of this teamwork, I would like to underline the contribution of Apostolos Zikas, who is this happy man, who is considered as one of the authority in left atrial appendage closure. Thank you very much.
Thank you so much, Professor, for your very insightful case presentation.
And the last but not least, Professor Vasilis Vasiligos gives me great pleasure, Professor of Cardiology, then the Director on the 3rd Cardiology Clinic, the Department of Cardiology, Hippocrates General Hospital in Thessaloniki. Vasilis.
Dear Presidents, dear Chairs, thank you very much. I'm the last one, so I'm going to relieve you. Thank you, Ioannis, for your kind invitation, and I'm going to show you a common case, which is not very common, but I decided to present this because there are many mistakes in a row. This is a patient who had sinus tachycardia, 100 beats per minute, or that's what it was diagnosed with. So she's an old, relatively fragile lady with preserved preserved ejection fraction heart failure. She had coronary artery disease, hypertension, hyperlipidemia, etc. So her medication consists of what is expected for this kind of situation. And a couple of years ago, she was hospitalized for worsening of heart failure in a district hospital. By that time, she had a small rise in the troponin, so the diagnosis of non-ST infarction was made. The coronary angiogram showed that all vessels were patent. Her ejection fraction was decreased now, and the ECG showed a tachycardia 95 to 100 beats per minute with prominent P waves and a left band branch block. Also, she had similar kind of heart rhythm with band branch block as well, but slower. At that stage, she had an electrophysiology study, but in a district hospital, not in a tertiary center for EPS. And that was reported as normal. So you have a patient who has worsening of heart failure, heart rate 95 or most of the time, and she comes with worsening of symptoms. So what do you want to do? An MRI of the heart, optimize the heart failure treatment, or she has LBBB, are you going to implant a CRTD? So, what? So you can scan and answer. Heart failure patient, MRI of the heart, optimize the heart failure treatment because he was in less drugs, or you're going to implant a CRTD. She has indications for a CRTD. She has LBB and a tachycardia and worsening. So we chose to optimize her treatment first because she was suboptimal. We didn't want to do an MRI heart because at that time we didn't need that information. It's okay to have that information, but it's not essential. And also, we decided not to implant at that stage a CRTD because according to the guidelines and to clinical practice, you have to optimize medical treatment and then decide for that. So after a few months, she came to our department with worsening symptoms, ejection fraction similar, palpitations, but she was worsening on her optimum heart failure treatment. So you need, you have to remember that she had a history also of hyperthyroidism, and you have this patient with 95 beats per minute. The bloods we did were normal. She didn't have any anemia. She was not thyrotoxicosis. And this is the ECG. So you see that you have a tachycardia. It's almost a tachycardia, 95 beats per minute, with P waves and QRSs with 1-to-1. So somebody could say this is sinus tachycardia. But Professor Fragakis, who has a better eye, would argue that, okay, this is a sinus tachycardia probably, but it could be something different. So if you want just to check the polarity of the P wave in lead 3 and lead AVF, if it was sinus tachycardia, probably this polarity would be positive. This is biphasic. The general practitioner or the general cardiologist may not be able to distinguish that. Or sometimes, you know, they say, oh, funny. But an experienced electrophysiologist would point it out, especially in a patient who has symptoms. You did what you should do for that. If you would cure or make her heart failure better, you would expect the heart rate to get lower. So what are you going to do now? Circulatory support, Holter, ILR, the implantable recorder, or you're going to do an exercise test to see what the heart rate is doing. So the correct answer is what you've chosen. It's easy. It's one of the few cases that we want to do a